counselors. You may need occupational therapists and lawyers and perhaps others, So you need a multidisciplinary approach, but it's difficult to coordinate. And victims may decline intervention even after you have confirmed it. Some of them have no mental capacity to make decisions. And intervention sometimes would mean separation. You will need to go to a nursing home. And that's why to the senior, when they're being abused, it is suffering. And when the abuse is being stopped, they have to move away from their home. It is also unbearable. And managing and preventing elder abuse frequently requires long-term care because seniors, because of aging, because of frailty, gradually you lose your ability to perhaps do simple shopping, house chores, and then gradually lose your ability to shower, to dress, to use the toilet. In order to protect the senior, you need to organize long-term care at home, in a community, or perhaps build sufficient nursing home, which is of course the last resort. So always try to take care at home. And long-term care is a hard nut to crack. It's not, you need highly skilled workforce in large quantity, and then it is costly, and it is very difficult to govern. So managing elder abuse means you need to have a good long-term care system in the community, which is difficult for a lot of countries. So let's talk about case management. What is case management? I would suggest that case management is the most sustainable, accessible, equitable way to provide long-term care for the frail seniors in the community. Case management is really a very intelligent, very caring agent who is a gerontologist, but also a bit of a nurse, a bit of a social worker, and knows enough about health. And then to look at this person, to do a comprehensive assessment, do planning and facilitate and coordinate services so that all the formal services and informal services come together and play a harmonious symphony. Okay. And then so the older person feels supported and the family members are not shortchanged at the same time. The caregivers feel supported to support the frail senior. So this is essential system of case management. First, you need to do case finding. Where are the seniors? How should we engage them? And for all the seniors, you need to identify who needs case management. You need to identify those who are frail, those who are vulnerable. And after you identify them, you need to do a comprehensive assessment to identify their needs because elder abuse, it usually is a sentinel event when care is broken. Okay, so but why the care are broken? Because the needs are not met and the caregivers have needs and the seniors have needs. So you need to identify what are the needs. And then you need to do a plan. How do you meet the needs? In certain villages, certain counties, certain cities, not all services are available. Even if they're available, some of them are not subsidized. You need money, to pay for them. So you need to identify what are their needs and then coordinate and implement either from informal resources such as family, extended family and neighbors and volunteer groups, or the OPAs, older persons associations, or you need to advocate for the government to do something. And then we need to continue to follow up, and then sometimes you escalate or sometimes you stand down because you cannot be so intense for too long. And then you need to do proper documentation and you manage operations. You need to have sufficient quality assurance and governance for this. And this part is the key, needs assessment. For those geriatricians or physicians in the crowd and gerontological nurses, this will be very familiar. I won't be going through this with you. This is the typical process of geriatric medicine. You need to do comprehensive assessment. That's where, so we are talking about elder abuse, yes, but if you're managing a victim of abuse, it is not just the abuse. There is also vision, hearing, functionality, multiple chronic diseases, lists of medication to use, nutrition, hydration, bowel movement, incontinence, mood, cognition, social caregiving. So you need to do a full assessment. So applying case management approach, this is a summary, it's a flow chart. So usually as a community worker, in my case, I'm a medical doctor. Doctors are a bit expensive, but in case you do have community workers, so they could see a person who is suspected of abuse, then they will need to do a comprehensive needs assessment. This need not be done by a doctor. If you can have a very good template, like what we did with in Indonesia, in Vietnam, in Mongolia, we could train train volunteers in the villages to do this. If you can have a simple enough template, and then they can actually do the comprehensive assessment to identify cognitive functions and so on. But in this assessment, especially if you suspect elder abuse, you need to ask a few questions. What is the risk of mortality and morbidity due to the abuse? How certain are you that there is an abuse? What is the decision-making capacity of the senior, of the victim? What are the protective and risk factors? That is from the function, the social resources, everything you can culminate into this, and then you develop a care plan. For those who are high risk, meaning high risk of certainty and high risk of mortality, morbidity, and there is no decision-making capacity, in Singapore, fortunately, because we have laws, we can invoke the Mental Capacity Act, MCA. We can also consider activating the Adult Protection Service, which is governed by the Vulnerable Adult Act, a new law. I'll be touching quickly later. So we can invoke the law to separate. High risk, no mental capacity. High risk, but there's mental capacity. And typically, the senior doesn't want segregation. But then we never know. So we should ask for consent. Can I separate you? Usually, urgently, we will admit to a acute hospital and will communicate with the hospital team about the situation. But if the senior refuses, then we will have to inform the senior of the risk, and we give the emergency contact and inform the options of protection, the Vulnerable Adult Act and the Women's Charter and so on. So, and the, or we can, and we also consider activating the Adult Protection Service and the Protective Service agency, which is a specialist. Low risk cases, and there's no mental capacity, usually what we do is we will try to reduce the risk, try to do counseling, and we will engage the donee. Not everybody has a donee. Donee comes from our Mental Capacity Act. In the Mental Capacity Act, there's this article called the Lasting Power Attorney. And if the senior have awarded the lasting power attorney to somebody else, that person is known as a donee. This donee is bound by law to ensure the welfare of the senior. So we have to engage donee. You're responsible for this senior. And if you do not act appropriately, the law can come after you. You can be charged in court. So increase the frequency of surveillance. This is for low risk, no mental capacity. Then the caseworker can visit more frequently. Lastly, low risk, but there is mental capacity. Then we will also inform the elder and explore other kinds of care arrangement. We give the emergency contact and advise that perhaps you should elect a donee under the LPA and so on. But that's not enough, because as a case manager, you take care of a person, a victim of elder abuse. It's not just elder abuse, you have to take care of the whole person. So you need to maximize the protective factors and reduce risk factors. For example, if there's mental capacity and the person is a bit disabled, you should try to optimize the function so that the person is as independent as possible. If there are medical issues not treated, then you will want to look into medical treatment, daycare. Maybe you want to, if the house, if there's a certain police station nearby, you can actually inform the police to increase the frequency of patrolling, counseling of the perpetrator, reduce the caregiver stress. Sometimes elder abuse occurs because the caregiver has got mental health issue or is burnt out. But of course, this is not a mitigation. It's not a right thing to do. But then, I mean, it's not explanation, but it's just that in family, sometimes this is the behavior, and and if there is a potential for reconciliation and rehabilitation, we would like to do that too. So case management, coordinate for resources, and then work towards a more long-term sustainable care and support system, and engage the suspected perpetrator with the purpose of support and rehabilitation. I have been doing this and it is quite, and it works. A lot of time, I've got perpetrator who is very rude to the senior, sometimes even threaten to be really violent and hit the senior and all that. But if I can do all this, I have very good outcome, by supporting the whole family as a group, but with a little bit of the law to be behind me. So sustainable intervention lies in the holistic approach in case management. We need comprehensive assessment, we need care planning. And elder abuse, for the doctors in the room, we cannot wait for it to be confirmed before we act on it. Recently, I have a case. It was not certain, and so it was dwindling, and it was being cooked and observed. But subsequently, a lot of family members were traumatized because of the abuse in the family. Although it's not a very violent one, but it was very disturbing. So we don't wait for it to be confirmed. Once we suspect, we need to act on it. And when we take care of a family, we work on reducing the risk and improving protective factors. Homebound elders are the highest risk group. So we need a system whereby we case find, identify, penetrate into the houses through village workers, through older persons associations, OPAs, volunteer group. Okay, and elder abuse is frequently associated with caregiver stress. So I would like to really bring our attention to support caregivers decisively. Recently, the Interi, where I'm a member of, we are working on a caregiver needs assessment instrument called Interi Scan. So those who are interested, you can write to me. I think caregiver support has been underappreciated. We need to do something about supporting caregivers. Just to share a little bit about the laws, because of this law, as a community doctor, I find it easier. Before the law, I have to go to the house and say that, oh, the blood pressure is too high, you need to go to the hospital, and just using such trickery to separate the victim from the perpetrator. But now with the laws, I don't have to do this. I can use the laws skillfully. So this is a framework. There are low risk, and in Singapore, there are family service centers. They are all trained to assess the risk and manage family issues. Moderate risk, we have a protection specialist centers. There are altogether 3. They can provide integrated services, and they are supported by family protection teams. They have got specialists to provide consulting for them. But for the highest risk, we have the Adult Protection Service, which is under the governance of the Ministry of Social Welfare. We call it Ministry of Social and Family Development. So they are the law enforcement, okay? And they have a lot of power. Okay? And these are the legislations. Penal Code is for serious harm and criminal issues. But there are altogether 4 laws that protect seniors. The Vulnerable Adult Act is the newest. In this act, the law has a definition for abuse, okay? And in this act, it included self-neglect as part of the protection, okay? Protection from self-neglect, Vulnerable Adult Act. Mental Capacity Act, the main purpose is to help a person, an adult, to elect somebody to make decisions on my behalf when one day I lose my mental capacity. And this person is known as a donee, okay? And how does this protect against elder abuse? If I develop dementia and I'm found to be neglected, the donee is liable. Okay, before this act, the family member, by culture, I have to take care of my mom, but by law, I don't have to. I don't even have to. So there's no protection. Women's Charter is very old. It was started to protect against spousal violence, but now we have updated it that can protect seniors, whatever sex or genders. Women's Charter. Maintenance of Parent Act is quite controversial. It is about parents having the right to claim sustenance from their children. So it's very controversial because a lot of families are broken over the years, and the act empower the seniors, and the children are a lot of grievances. So it is usually more arbitration than invoking the law. So my last slide, in conclusion, Aging is a biological reality. The psychosocial experience, however, is optional. Detecting, assessing, and managing elder abuse poses a different kind of challenge from children and spousal abuse. Elder abuse has a biopsychosocial causation, and it requires a biopsychosocial solution. Managing elder abuse begins with raising a suspicion and ends with a sustainable and person-centered care arrangement. Intervention frequently revolves around maximizing protecting factors and minimizing the risk factors in all biopsychosocial domains. An integrated health and social care approach by an interdisciplinary team is required in every step of the way, especially in key junctures of decision-making and execution. However, this is difficult to coordinate. Case managers play a key role to facilitate integrated and person-centered care, and this is a cheaper way of doing integrated care. With policy framework and laws, case management for elder abuse has been much supported. Okay, so with that, I will stop my sharing. Thank you.
Thank you, sir. Thank you for the address. And now I would like to invite Dr. P.B. Desai, the Secretary, RC12, to propose the vote of thanks for officially concluding this inaugural session.
Okay, thank you, ma'am. Hello, I'm Dr. Pratibha Desai, the Secretary and Associate Professor, Department of Sociology, Shivaji University, Kolhapur. First of all, for this, the All Indian Sociological Society and RC12 has been conducted an international seminar in the association's collaboration with the VIT, Department of Social Science, School of Social Science and Languages, International Network for Prevention of Elder Abuse and Development Welfare and Research Foundation, and international webinar. And particularly theme of this webinar is the elder abuse, a public health and well-being of the challenges. And respected dignitaries, the organizing convener Mala Kapoor and the convener Prabhakar sir, co-convener Manjushri madam, and the praiser Balakrishna, and other dignitaries all. I welcome. I must thankful the today's welcome address, and it was the message given by the Professor Dr. Maitri Chaudhary, the President of ISS, retired Professor of Sociology, Jawaharlal Nehru University, and she has given her inaugural message addressing the elder issues and how much the elder population is to be the going on, and it has become a serious population. Thank you, ma'am. Thank you for sending the inaugural message for this inaugural sessions. And I must also thankful Professor T.V. Sekar, the International Institute of Population Science, IIPS Mumbai, and is the PI at longitudinal aging study in India, and where he has given that means he has given the detail of his longitudinal project and the concerning with the survey of the older persons, and which was to be conducted by the IIPS, and how much it is useful for the budding research scholars. Thank you, sir. Thank you for giving the very thought-provoking presidential address. And I am very much thankful for the special match for Sushana B. Somer, the JD president of International Network, and she has also given a special message for this inaugural sessions of international webinar. I now come to the keynote address. It was to be given by Professor Mala Kapoor, the Shankar Das, the sociologist and journalist and health social activist, and she has given the social, medical and biological, all the aspects of the elder abuse and the strategies, and she has suggested to develop a strategies for the scholars to address the elder abuse particularly. Thank you, ma'am. Thank you for giving the keynote address. And the special address, which was to be given by very detailed concerning how the case management approach was to be useful for managing the elder abuse, and he has given all the still from definition of the old age to the case management, and also the some recommendations and to identify the challenges, and for example to study with the multiple approach and by using the case management approach. Thank you, sir. Thank you. Dr. V. Nagan, founder CEO, and he is the head of the Clinical Development Home Nursing Foundation, Singapore. And I am very much thankful all the delegates, our participants who are attended, and they are rigorously they are attending, and I have seen also some participants are taking the notes. That means it sees how much they are to be interested particular this webinar. I am very much thankful all of you, and I, with the permissions of the president and all the dignitaries and convener, I am here declare that the inaugural session is the over. Thank you, and you will be still here for next technical sessions. Thank you. Thank you.
Thank you, ma'am. Thank you for the vote of address. And now the inaugural session is officially concluded, and we'll move on into the technical session. I would like to invite Dr. Mala Kapoor Shankar Das to introduce the technical sessions and the experts.
Thank you very much. So let's not waste any time and move forward. But I do want to stress that it is very important for all of us to stick to the time allotted for each speaker and for each technical session, so that we can keep up to our program in a dignified way. Now, the first technical session, let me tell you, there are 3 technical sessions. So the first one will be on elder abuse, a crisis and combating strategies. And we have 7 presentations in this. Just in case there is a few minutes left, then we might have 2 research scholars from Dharabad, Professor Jayashri's students, to briefly talk of their research. But I am seeing that we are running short of time. And importantly, we have 2 very learned professors here as the chair. So we have Professor M. Tamilarasan, who is the professor and head Department of Sociology, University of Madras, India. And then we have Dr. Amindra Mohapatra, who's a scientist with ICMR, India. Now, what I do want to stress is that the format which we are going to follow for these technical sessions is that there will be opening remarks by one chair, and there'll be closing remarks by the other chair. So we have kept 2 chairs for every session. And again repeating, I request the chair to moderate in such a way that we keep the time in mind, and all the speakers to please not exceed beyond their limit. And also what I do want to state is that we are not going to introduce any of the speakers, because Dr. Prabhakar has done a great job of putting their slide on the sharing it, which has their details, and they should straight away start with their presentation. And we will have few minutes for discussion, but what we mean by that discussion is that everybody, please, if you have any comment or any question, put it in the chat box. And the chair and the co-chair will have a look at it, pick up the important issues, and very briefly address it to the respective speaker. And they, within, I think, 20 seconds or so, can give a prompt reply. And if the reply is longer, they can connect with the question whoever has put on the chat box. We are really constrained for time. In fact, I had to drop out many speakers because of the time constraint. The response has been tremendous from speakers who wanted to share their work. And also we were keen to have many talk about these issues. The second session is on concerns related to abuse, healthcare, and wellness. And this has also 7 presentations. And this is chaired by Dr. Manushi Srivastava, who's Professor, Department of Community Medicine, Institute of Medical Sciences, Banaras Hindu University. And she's also the co-convener of RC12. And also by Chair Dr. J. Bala Morgan, who is the Associate Professor of Sociology, Department of Social Sciences and Languages, Vellore Institute of Technology. As you would be realizing it, we are keeping the chairs from India because our intention is that these technical sessions and the full program is going to guide our students, our faculty, and all those interested from India to work more on this very important issue of elder abuse and aging concerns, which is dominating the global scenario. And we have some fantastic scholars from India who can make wonderful contributions in taking this forward. So this meeting by RC12 is basically to take forward this field. The third session, technical session, is on intersectional perspectives. And again, we have two people chairing it, Professor Dr. Ruby Bhardwaj, who's from Department of Sociology, Janki Devi Memorial College, University of Delhi. And then we have Professor Dr. K.M. Ziauddin, who is the Associate Professor and Head Department of Sociology, Maulana Azad National Urdu University, Hyderabad. So the rule of how to conduct the technical session applies to each of the technical sessions. And in this third session, we have, besides the expert speakers, we also have 3 paper presentations. And very brief, the paper presentations are going to be extremely brief. And again, we want to emphasize that if there is little bit time, there are 2 young scholars who want some opinion about their research, so they can also be accommodated. So now what I want each session, technical session chair to start, and we start with technical session 1. And just remember not to introduce the speaker, to keep to the time limit, to keep checking on the chat box for any comment, and the speakers to respond very briefly within few seconds, and rest of it to put in the chat box. Thank you all for your support, and you would agree with me, we need time management. It is very important. So the first session, Elder Abuse, a Crisis and Combating Strategy, is going to get started.
Thank you so much. So I wish to express my gratitude to Professor Mala Kabul Sangradas as the organizing chair of the international webinar, and the webinar convener, Professor A.S. Prabhakar. And I thank for both of you for being invited me to be as a chair in the first technical session of the international conference on the public health and wellness challenges of elder abuse. So why the technical sessions? One topic, the theme 1 says about it, elder abuse, a crisis and combating strategies. And with the permission of the chair, I like to ask that the time schedule for the speakers. Actually, there are just 7 speakers. Now we are in 3 p.m. right now. If you follow the actual time schedule from 10 to 12 minutes, it will take 1.5 an hour. Is it permitted to go by the similar timing, 10 to 12 minutes, or any changes to be needed?
Please, request is if speakers can keep it to 10 minutes, please.
Yes,
that would be greatly appreciated. And if also the discussion can be put all in the chat box so that we can cut down on that thing. Maybe as chair, you can just remind the speaker that there are some comments for them in the chat box and they can respond there. So that would we'll save some time on the session. Yeah, my apologies, but I think we need to take this step.
Thank you. Thank you so much, ma'am, for your kind clarifications on this. respected speakers and organizers, and dear colleagues and fellow friends and the paper presenters, and esteemed paper presenters, those who are joined in the international webinar on elder abuse, public health and well-being challenges. I'm happy to be chair the session along with my senior Anna, Dr. Amarendra Mahapatra, scientist F from Indian Council of Medical Research from Bhubaneswar in Odisha. So I'm really happy to join with you, sir, and being in the technical session 1. Sir, you are joined here?
Yes, I've joined. I've joined.
Yes, sir. Thank you, sir. Thank you. Actually, it's being joined with the elder Anna to be in the session. I'm really giving me a great pleasure to be joined the session because he's one of the mentor to doctors to be into the RC12 of the sociological health, aging, and well-being of Indian social society. So, with the gratitude and glad, I invite the first speaker of the first technical session. Is the topic of the paper Elder Abuse in Indonesia, a Silent Crisis by Denin Agustin, a Center for Family and Aging Studies, University of Respite, Indonesia, and Dr. Tilak Matlina, Doctor of Mental Nursing and Practitioner Neurologist Program. I welcome you to start your presentation, please. Please kindly stick to the time as the organizer has stated, please.
Thank you very much. Am I audible?
Yeah, you are audible.
Yes,
Thank
you are
you.
audible.
Good afternoon, everyone. Thank you very much for the organizing, for inviting us from Indonesia. My name is Dini, and my colleague, Dr. Tika Mariana, would like to provide an overview of elder abuse in Indonesia. So the next slide, please, because the time is very concerned. I'm sorry for the next slide, please. Or should I share the slide or the organizer? Oh, okay, thank you. So for the introduction, this is explained about how the elder abuse by the WHO perspective. And then by the National Research Council perspective. Yeah, I think we don't have to explain more about the elder abuse because already known by everybody. So the next slide, please. Yes, Indonesia, like many other countries around the world, is expecting a significant demographic shift. The percentage of the population aged 65 and over is steadily increasing. Just like the slide show here, that the life expectancy of Indonesian aging population are increasing steadily, and global polemic increasing prevalence of chronic disease and increasing risk factor for preventable injuries this is for the elder abuse. So the approximately around 15.7% of people aged 60 years and older have experienced some a form of abuse in past year. This is according to WHO 2020. And also the prevalence of older abuse varies across country. This is from the United States. You can see around 11.4%, and Ireland 2.2%, and in China is about 36.2%. Meanwhile, the recent study indicate that elder abuse is a significant concern in Indonesia. Is according to 2022 report by the Indonesian National Commission of Elderly, it is approximately around 15% of older adults reporting experiences some form of abuse. The elder abuse is in Indonesia from the physical abuse around 18.18%, from emotional abuse around 97.70%, from sexual abuse 13.64%, and economic or financial abuse around 31.82%. Neglect around 61.36% and abandon 29.55%. This is according to the research. However, actually number may be higher due to underreporting and stigma. Next slide, please. This is the type of elder abuse. From the elder abuse is a serious issue that can take many forms. The understanding the various type of elder abuse is crucial for identifying, preventing, and addressing this harmful behavior. So from this different type of elder abuse, from physical, this is implying physical harm or using physical force that result in injury or distress. For example, hitting, slapping, or pushing, or retraining or confining an elder without consent. And the second is neglect. Neglect is failing to provide adequate care or meet the basic need. The example is ignoring the basic need for food, water, or medical care. And the third is physiological or emotional abuse. This is causing by emotional distress through verbal or non-verbal means. The example, verbal assault, threats, or insult, or intimidation, or humiliation. The fourth is financial or economical abuse, that misusing or exploiting an elder's financial resources for personal gain. For example, stealing money or their property. And fifth is violation of the right. So the violation of the right is the basic rights such as freedom, owning property, meeting or speaking, or being secretive. Yeah. And the last is sexual. Sexual means sexual activity without consent in various form, or non-consensual sexual contact or behavior. Example is rape or sexual assault. So the risk factor. The last slide is the risk factor. Elder abuse can occur due to a variety of risk factors that affect both the either individual or their caregiver. So understanding this factor is essential for prevention and intervention. This is for the first is individual factor that consists physical and mental health problem, dependency, and social isolation. And the second is relational factors from the caregiver stress, family conflict, or abuse caregiver. And from the community factor is lack of support services, cultural norms, and economic stress. And the fourth is from societal factor. So as you know, in Indonesian culture, there is a strong emphasis on the family duty and respect for the elders. So traditionally, the elderly are referred and expected to be cared for by their children or extended family. However, this idea is not always realized in the practice. Yeah? So understanding the risk factor can help in identifying potential situations where elder abuse may occur and inform preventive measures. The next slide, please. This is investigating cases. For elder abuse require a careful, sensitive approach to ensure the safety and well-being of the elder. Involve a structured process for investigating this case. The first is investigating initial assessment and screening that contain observation, interview of the elder, screening tool, and the second is gathering evidence from the medical examination, photographic documentation, and financial record. The third is interviewing relevant parties. And sorry for the slide is not clear. Yeah, the fourth legal and social intervention. Fifth is follow-up and monitoring. Six is documentation and reporting. Next slide. Hello. Yeah. How to prevent the elder abuse through a lifespan approach in mental health will be presented by my colleagues, Dr. Tika Marliana. Time is yours.
Thank you, Mrs. Dini. First of all, we would like to express our deepest gratitude to Dr. Mala and all of the committee for providing us with this valuable opportunity. We feel incredibly fortunate to have gained so much knowledge from the insightful presentation of the expert today. We believe that today's discussion marked the beginning of a broader campaign to combat violence and mistreatment against the elderly. Sorry, may you back for the last slide first?
Yeah. Two more minutes for your
Okay,
statement.
thank you.
Please.
The previous slide, please. Okay, thank you. Mrs. Dini has talked about elder abuse in Indonesia, particularly from a public health perspective. But on the other hand, we think that addressing elder abuse require looking at the psychosocial development stage experienced by the elderly, because unfulfilled developmental stage from previous period may affect their mental resilience and then making them a vulnerable group susceptible to abuse. We can see in the screen that the human psychosocial stage that the elderly have the task of developing self-integrity, which means feeling satisfied with their life achievement. And this is essential for individual resilience in the elderly stage, according to the lifespan approach stage. However, in reality, there are many elderly people who find it difficult to trust others. As a result, they can be easily influenced by the actions or intimidation of others. This behavior can be traced back to a lack of trust formed in infancy, the first stage you can see here. Or in some situation, we come across many elderly individuals who struggle to make their own decision and often experience feeling guilty. This is not only because of their dependence of their children for financial or emotional support, but also because their development during early childhood in the toddler and preschool may not have been fully supported. So it is crucial to embrace life review therapy or such of reminiscence with the elderly, so they can recognize the time they've missed that take immediate step to fulfill it. This approach can help them achieve holistic health, both physically and mentally. Next slide, please. Yeah, in the context of mental health services in Indonesia, it is imperative to prioritize the promotion of mental well-being among the elderly. This involves providing health promotion for healthy elderly individuals and educating those at risk of psychosocial problems, and then offering immediate treatment and rehabilitation for those who have experienced mental health disorder due to abuse. The objective is to facilitate their prompt recovery and enable them to resume their daily activities. And then next, We have conducted research too on the vulnerability of the elderly with regards to mental health and psychosocial support training based on WHO model prior to training the elderly. But we first train health worker, then followed by community leaders, cadres, and then caregivers. This approach aims to ensure the sustainability of the community-based mental health care system. Okay, next slide, please. And this is the result. After the training of MHPSS, we can see the data after receiving online mental health and psychosocial support services. The intervention group showed significant improvement in mental and emotional well-being, and the level of loneliness decreased in both in intervention and control groups, and the experimental group improved in achieving self-integrity, the task developmental for elderly, while in the group showed less improvement. Additionally, the ability to achieve psychosocial developmental tasks in the elderly significantly improved after receiving mental health and psychosocial support. The last slide, please. So, in a conclusion, next, our final presentation underscores the imperative for unified action from the government, civil society, and the public to protect the right and well-being of older adults in the face of elder abuse, especially in Indonesia. And then we recommend to embracing community-based preventive measures and embracing a comprehensive lifespan perspective offers transformative approach to nurturing the mental resilience of senior citizens, and then fostering self-integrity and promoting a proven sense of contentment. This is all of our references. Thank you for the times.
Thank you. Thank you so much. Thank you so much to Daniel Agustin and Dr. Tika Martilina. So for your wonderful presentation, I request the participant to be noted down your questions and the clarifications what you needed. I think the end of the sessions that we can have a clarifications for your questions. Please. Thank you. I request even the presenter to be with us till end of the session. Thank you.
Thank you very much.
Yes, I request the second speaker, the second topic, Caring for Vulnerable by Joel Roy. You accept? The second speaker, Dr. Joel Roy. You accept? Sir, have you joined with us? Sir, shall we go to the next speaker, sir?
Yes, you can go to the next speaker.
Yeah. So thank you. So since he is not joined, the second speaker is not joined with us. So shall we go to the next speaker? The next paper, Development of Elder Abuse, Preventive Services in Taiwan by Professor Dr. Pei-Zhen Yong, National Taiwan University. Ma'am, you are here? Yeah. Welcome. Thank you. Please, you can start your presentation. Preventive Services in Taiwan by Professor Dr. Pei-Zhen Yong, National Taiwan University.
Can you hear me?
Yeah.
You are here?
Yes, I'm here.
Yes, madam, we can hear you well. Yeah, please.
Okay.
Yeah.
Thank you very much for inviting me to this important seminar. Can you hear me?
Yeah. You are here?
Yes, I'm here.
Yes, madam, we can hear you well. Yeah, please.
But I hear another speaker for inviting me to this important seminar.
Hello.
Hello?
Admin, please check that. Any other persons unmuted?
I hear another speaker for lag. I think there's a lag.
Ma'am, actually your speaker getting echo, ma'am. You can off your speaker.
Admin, please check that. Any other persons unmuted? Yeah. I request.
Yes.
Yeah, I request all the participants kindly mute your mic while the presentations take place. Please, Ma'am Young, you can go ahead with.
Okay.
Yeah.
Thank you. Thank you for inviting me. And my presentation today is on contextual framework and interventions for elder abuse in Taiwan. Next slide, please. Next slide, please. Next slide, please.
No, ma'am, who is supporting you for the slide changes, ma'am? It's not moving?
The slide is
No, sir, it is from the admin only.
Admin. Okay, okay, okay. There, please.
Kirtana, please change the slides.
Yeah. Please help me. I'm not allowed to share my screen. Okay, great. Next slide, please. Yes. Okay. I think that similar to everybody else, we applied to the United Nations 5 principles of for older persons, including independence, participation, care, self-fulfillment, and the dignity. For example, in many abuse cases, if we try to just place them in elderly institutions, that may deprive them of independence. So we always need to remember the 5 important principles because that's very basic for their human rights. Next, please. I want to introduce some important legal foundations in Taiwan. Number 1 is we have encoded in the civil code that the family need to support their elderly parents. In 1980, we had the Elderly Protection Act, and 1988 we had the Domestic Violence Prevention Act. 1996 we had the Sexual Assault Crime Prevention Act. And in 1997, we revised the Elderly Protection Act, added a chapter on protective measures. Ever since then, we have very clear legal premises for our elderly abuse protection. But as population aging, we also see a fast increased number of cases in elder abuse. Taiwan is approaching the super age society in 2025 with over 20% of the population older than 65 years and older. That will be 4.2 million people. About 2/3 of the elderly people live with their family members, and the other 1/3 live alone and with spouse only. Among the elderly people, about 12% are with disability and they need care. Ratio for elder abuse was 8% in 2019, with mental abuse the most common form, followed by physical abuse, financial abuse, and neglect and self-neglect. Next slide, please. We have a very special abuse category in Taiwan prescribed by law, which is for low-income vulnerable elders without legal family members. Okay, because the civil code requires family members to support their elderly family members. So if elderly people who need care for daily lives, including financial support, activity and the daily living and the instrumental activities of daily living care, or if they go to hospitalized and they need care for 24 hours hospitalization care, or they need rehabilitation visits, etc. They need to have their family member or some relatives to care for them. If they don't, then they fall into this special abuse category, meaning neglected or abandoned by their family members. Next, please. There are two main fields where abuse cases occur. The most primary scenario is within families. And the primary type currently among reported cases are within families. But it doesn't mean that institutional abuse is not an issue, mainly because it's very difficult for abuse cases in institutions to be reported, and it's even more difficult to be intervened. Next, please. The following are our interventions. Number one is public education for all citizens in all ages to fight against all forms of abuse. We even have educational programs in elementary schools to teach young children to be aware of their abuse, possible abuse situations in their families. And we have a national hotline service. Anybody can pick up the phone and call 113, and there will be a 24-hour hotline attendance to receive the call and make consequent interventions. And now we are building an integrated service network among civil, social, medical, and the police departments. The primary authority is the county and the civil authorities. They are in charge of the local network. The service includes, but not limited to, medical treatment, removal and replacement, psychological and emotional assistance, family counseling or negotiations, low-income family support, legal assistance, and the case management. Next, please. We have a lot of challenges facing the number of abuse cases. Number one is lack of understanding and awareness of abuse and neglect. Many people mistake abuse with elderly frailty. And so we need to understand more about older persons' physical, mental, and the cognitive conditions and the common diseases. And we need to differentiate frailty from illnesses or dementia. And right now we are facing a serious lack of trained professionals. For example, in social work fields, we have a very high ratio of turnover, and a similar situation occur in hospitals and the nursing care services. We also face insufficient training and education for multidisciplinary team workers. So sometimes professionals work in silos. Next, please. There are special cultural challenges. The most highlighted one is family shame. People don't want to let their neighbors, let alone the general public, to understand their difficulties because they will be considered inferior. And another current challenge is drug and alcohol abuse. Okay, with the global drug market we are facing more and more challenges with this regard. Mental illnesses is also a challenge. We see a toxic negative codependence among family members, especially with people with financial and mental health issues. Next, please. Next, please.
Ma'am, you have 2 more minutes, ma'am. Please.
Yeah. And 你可以给我印下我的那个。Oh, and we also face societal challenges such as social exclusion and mistaking abuse with normal aging. And right now in Taiwan, because of our super low fertility rate, causing population decrease and also decrease the family caregiver manpower. So more and more elderly people are not being cared, sometimes even causing abuse. Next, please. In year 2014, I was commissioned by the Ministry of Health and Welfare to develop assessment tools in Taiwan for elder abuse. And the outcome was a 14-hour training module and also an assessment tool. Next, please. Later, following that 2014 assessment tool, we developed an AI-assisted assessment system to help professionals. Once the case was reported, then there are a series of questions for the reporter to put in data. Once the required data was filled in the reporting system, social workers will be suggested that the reported case is a red light, high risk case, yellow light, medium risk, or a gray light, low risk case. Then social workers may accept the suggestions and make due interventions, or they may disregard the suggestion and go ahead with their own care plans. Next, please. The next slide you can see, I'm sorry, I'm just copying the Chinese screen. You can see on the right side, with each question, they will be given by the AI system a computational number. Then all numbers together, then the case will be categorized into red lights, yellow light, or gray lights. Next, please. After the AI-assisted system was implemented, we realized that social workers, due to the lack of manpower, they can only open, for example, half of the cases. Then the rest of the cases will not be taken care of. So in 2022, we started the so-called elderly abuse preventive services. Okay.
Excuse me, ma'am. I'm sorry, ma'am. Actually, time up, please. You can conclude, madam. I'm sorry, ma'am. Actually, your time up.
Okay.
Yeah, please conclude. Yeah.
Yeah, I will finish up. So for the future development, we hope that we have further collaboration among the diverse government departments. And also we need to refining the technology assisted system. and the continued advocacy for human rights. Thank you.
Thank you, madam. Thank you. I'm sorry. Thank you so much for your time, the time limit boundary that we are. Because all others also be accommodated. Already we are little running. Thank you. Thank you for your wonderful presentation with the important findings and data.
Thank you.
Yeah. So with the few words and that I would like to request the next speaker, elder abuse, contemporary issues and policy, Professor Jashi ma'am. Upload Professor Jashi ma'am, please ma'am.
Yeah. Good evening.
Good evening, ma'am.
Good
Please.
evening. Good evening. It's not visible.
Yes, you are audible, ma'am.
I'm audible. Okay.
Yes, ma'am. Yeah, please.
Thank you very much. I take this opportunity to congratulate RC12 for taking this kind of a mega event at the international level. Professor Mala Shankardas Kapoor, Professor S. Prabhakar, and chairperson of this session, Professor Tamil Arasan, and co-chair, Dr. Mahapatra sir. See, my topic is elder abuse, contemporary issues and policy. With regard to India, I'm going to speak. This is the research conducted by me and my student, Dr. DGN Prashant. See, elder abuse is a complex issue that can emerge from different causes and roots in multiple factors. And it is a very difficult to detect also. Problem is hidden and concealed in nature because victim denies the abuse, does not report it because of guilt, shame, fear, and not being cared by others. So in that case, always it is a hidden nature. And it was existed earlier also. It is not a new concept adds together, but gravity has been increasing now. And it has gained a public recognition recently. And it is a fundamental human right violation. And here, our study found that there are many factors. I have already pointed out that there are multiple factors rooted in multiple situations. So it is a reciprocal thing. One is at the end, elderly people are also involved and caregivers are also involved. This is some kind of for example, child abuse, women abuse, all these abuses are within the family. And our study focused mainly on domestic setting. Actually, there are various factors we found out. I'll briefly explain, not explaining, dotted point I'll give you. So urbanization in India has actually precipitated these aspects because of so many issues related to it. And it's a complex technological development which has happened in recent years has also precipitated elder abuse and migration, especially the migration from rural to urban areas. Living in overcrowded house and financial responsibilities of the caretaker was also responsible for this. Care stress, because of job stress and care stress. Drug and alcoholic addiction of both parties, caregivers as well as caretakers also, even elderly also. Job loss for caretakers. Personal tragedy, for example, widows are more akin or more inclined or they will be abused more. Family conflict, dispute and property dispute. This is also one of the reasons for that. Cultural beliefs and spiritual abuse also happens because of cultural beliefs or divide in cultural beliefs. History of abuse is also one of the reasons we found out. Because violence in the family, they have been seeing the violence in the family, it has become natural for them to see that violence and they will become addicted to some kind of inculcate those kind of a violence and abuse. And for them, it is not considered as abuse or violence at all. That is one of the major reasons in Indian families. Lack of awareness about elder abuse is also one of the reasons. And women empowerment, though it is a good and positive point, but women empowerment and employed women are not able to cope up with the role conflict. At home also they have to do and outside also, and caretakers, less number of caretakers for elderly. And these women are the core caregiving individuals. In almost all studies, it has been proved also. And I'm not going to give detail about types of abuse. Here there are three things. One is self-abuse is also an abuse, and domestic abuse and institutional abuse. When we consider the type of abuse, domestic abuse, here we have found that there is a clear evidence that there is a feminization of aging that's also proved through our demographic transition and other factors. And widowhood, feminization of widowhood, now there is a feminization of elder abuse also. Naturally, there will be more number of women in the fag end of their life. Naturally, they will be abused more rather than men. So this is one of the reasons. That is why I say that feminization of elder abuse is very evident in our study. For abuse is related to so many aspects I have found out. So health-related abuses are more and it occupies the major chunk. And food-related abuses, finance-related abuses, property-related abuses, hygiene and addiction-related abuses. These are the abuses which are very, what you call, manifested in our study. So 71 to 80 years age group are more abused rather than the young old people. That means not oldest old also, young old, not old people. That is 71 to 80 years age group are more abused. Women were more abused. That I have already told you, that feminization of elderly abuse. Majority of the people are not having cordial relationship with the family. If you ask them, they say in a peripheral manner, they say yes. But when we go deep into their by keeping a rapport and other things, then they will reveal that there are certain kind of abuse we are also experiencing. Then majority of the respondents are living with sons in our study. And verbal abuse is more prevalent compared to other abuses. Abuse types of abuse has already been given by the other scholars. But here they are telling that this, okay. Both here, in a family setting, son and daughter-in-laws were the main abusers. So we can say that son is a breadwinner as well as caretaker of the family. In Indian ethos, there will be runas. Runas means debt, Pritra Runa and Matra Runa. But even here also, both son and daughter-in-law were the main abusers for elderly. Ill health was the main reason for abuse. Because of ill health, people are not able to, caretakers are not able to concentrate on elderly people. Naturally, ill health has become a major factor for abuse. Food-related abuse. Here, in this case, daughter-in-law was a main abuser because daughter-in-law prepares food and she will not give a diet food for the elderly people. Not only that, timely food, especially for diabetic patients, should have timely food, but they are not giving. So in that case, food-related issues, food-related abuses are more involved by the daughter-in-law. Financial abuse. Son is the major abuser because of property, because of conflict in the property, and because of division, that is property division. Son is the main abuser. And in Indian system also, we have changed the majority of the cases. There is a role because one person is looking after for a period of 6 months, one son. The other son is looking after for a period of 6 months. That means it's rolling on and on. So in that case, there will be so much of conflict with regard to property. Then finally, the elderly people will suffer. Hygiene-related abuse. With regard to hygiene-related abuse, daughter-in-law is also a main abuser. And there are spiritual abuse also we found. More between daughter-in-law and daughter-in-law is the major abuser. There are, for example, some cultural practices which have been conducted by the family and rituals conducted by the family will not be viable for the daughter-in-laws. Naturally, there will be daughter-in-law will abuse more for the conducting all these rituals and other things. And here there are many aspects which are because of paucity of time, I will give you some hints with regard to legislations pertaining to this elder abuse in India. For example, Article 41 has already been stated that state shall within the bounds of its financial resources and growth make efficient laws for assuring the right to the employment, education, and social assistance in case of employment and old age, disease, and disability. This is Article 41 says like this. And legislation and policies in India, we have several policies, not compared to women and children, not much policies are there, but there are policies. Hindu Adoption and Maintenance Act of 1956 has given some kind of a relief to the elderly people. The Code of Criminal Procedure of 1973 has also given some kind of a protection, maintenance, and ensures for their financial stability. The Maintenance and Welfare of Parents Act 2007 is an epoch-making act in Indian society. There was no special provision for the separate legislation addressing the issues faced by the elderly prior to 2007. This is the very good act which has passed by Government of India, Maintenance and Welfare of Parents and Senior Citizens Act of 2007. It is a legal obligation for children and heirs to provide adequate maintenance to senior citizens, and it proposes that state governments establish old age homes in each district. Actually, old age homes are naturally in Indian society, old age homes we never thought, but today it is a viable suggestions, viable measure in order to combat many problems of the old people. National Policy of Older Persons in 1999 also has opened a new vista in the Indian society. And national old age schemes were there. National programs for health care of the elderly are also there. These are the major legislations which have been passed by the government as well as in state governments. Some of these state governments have passed the law with regard to the safety of the elderly persons. For example, Himachal Pradesh government, Maharashtra government, those two governments have done excellent work with regard to this protection of the elderly people. And here, how to prevent elderly abuse. There are many speakers who have given generic ideas with regard to the prevention of elderly abuse, but I'm not going for a generic suggestions. So the
2 more minutes, ma'am.
Okay, I'll do it.
Sorry,
I'll do it, Professor.
Sorry, ma'am.
Yes.
Yes.
There are certain things I would like to tell you. Booklets should be distributed to elderly, mentioning the laws pertaining to them. This is one. Geriatric units in every hospitals, both private and public, should be given. Educate the elderly to keep sufficient finance with them. They should not divide the property before they make a will rather than dividing the property. Concessions in public transport, railway, flights should be reintroduced. Earlier it was there, now it has to be reintroduced. Pre-retirement counseling centers should be opened for retired people. Inculcate values of respect in school curriculum. Government should provide hearing aid and dentures with minimum budget. Fit elderly can work after retirement also. That is work after retirement. My article is also there in that. Healthcare workers in the vicinity should keep track of the elderly who are ailing. Crime against elderly should be curbed by using helplines. Panchayat and municipal corporations policies should have record of the elderly who are living in their jurisdiction. Police, not policy. Police people are also should have a record. And emergency phone numbers should be available to elderly. Daycare centers should be open. Medical and nursing care, old age homes, paid and free should be open. Encourage open communication between family members. That is nowadays lacking. These are my suggestions. Thanks for your patient listening and giving me an opportunity to present my views. So thank you, Professor Tamilarasan, for giving 2 minutes. Thank you.
Thank you, ma'am. Thank you so much. Thank you. So, thank you, ma'am, for your wonderful presentation. So with this, I request the next speaker on the topic Elder Abuse in Andhra Pradesh, Challenges and Strategies by Professor Vengalapati Venkateswarlu. I think our senior professor. Professor, are you? Professor, have you joined us? Yeah. Hello. I think professor is not joined with us. Professor V. Venkateswarlu sir is here in the online. Are you with us in the meeting? Sir, can you move to the next speaker, sir?
Yeah, now after 3 calls, you can go.
Yeah, yes, sir. Yes, sir. So now I think he is not, yeah. So now we call upon the next speaker, Professor S.K. Ramani ma'am, from Dr. Ambedkar Law University, Tamil Nadu. And her topic on elder abuse. Yes, sir, please, madam. Ma'am, are you with us? Madam? Ma'am, have you joined us for the webinar? I think not yet.
No.
Yeah, shall we move to the next speaker, sir? Then if they joined, all the three.
Yeah, please move on to the next speakers.
Yes, ma'am. Yes, ma'am.
And if we can finish this session early because speakers haven't joined, that's okay. We'll give them time later in case they can.
If they join, then we can give. Yes, ma'am.
Some people are finding it difficult to join because the Zoom link is exhausted.
Yes, ma'am.
And we are trying to shift them to YouTube.
Yeah, okay.
But maybe they'll join later.
Okay, ma'am. Okay, ma'am. Thank you. Thank you for your sessions. Yeah. Now, as for the suggestions of our organizing secretary of this webinar, like we can move to the next speaker. The topic, malnutrition in older adults and neglect, by Dr. Serin Obek Yashini from the University, Asek Erbil University, Turkey. Yeah, please, ma'am, you can start your presentation. Yeah.
Please allow me share my presentation, share my screen for my presentation.
Madam?
No. I can't. No.
She wants to share the presentation.
Yeah.
Ma'am, do you want to share?
Yes, I want to share my screen.
Okay. Have you already shared your? Okay, maybe the admin will do it. Yeah, please. Professor Prabhakar sir. Dr. Balamurugan.
Yes, sir.
Yeah, please ask your admin to share ma'am's PPT.
Yes, admin. Share for sharing PPT.
I can't sharing. I can't share. Sorry. I think it's okay. Hello.
Yeah.
Yes, ma'am, it's audible. Yeah, please, ma'am.
Thank you. I am grateful for inviting me. Thank you.
Ma'am, now you can share your PPT, I think. You have been made a co-host. You please try.
Yes, ma'am, you can try, ma'am. Actually, the presenter is enabled to present their PPT by themselves, ma'am.
Sorry, you can see?
Not yet, ma'am.
Yeah, we can see that.
Ma'am, you can share your PPT, ma'am. Now you are.
Yes, I am sharing. I am sharing actually. But I don't, yes, I'm sharing.
Okay.
We are able to see that.
No, not it, sir. Sir, can you see it?
Yeah, I'm seeing the second slide of our presentation.
Oh, okay.
You can see. You can see,
Yeah.
correct?
Only it's
Okay. I am starting, yes?
Yeah, start.
how it's not
Thank you.
visible for others.
However,
Yeah.
now,
Today I am talking.
Yeah, yes, ma'am. Yeah.
Can
now
I
it's-
start?
Yeah, yes.
Okay, thank you.
Yeah, please proceed. Yeah.
Today I am talking about malnutrition in older adult and neglect. First of all, I am talking about in Turkey. In Turkey, the proportion of the older population in the total population has been increasing over the years. And the older population rate, which was 3.9% in 1935, reached 10.2% at double-digit levels for the first time, 2022. Older adults, older adults can be seen as a dependent group and a burden by both society and their family. As a result, social and economic problems such as loneliness, poverty, disability, low level of education, need for care, disease, and disability. In addition to the increasing need for care, older adults who may be vulnerable due to their material and spiritual dependency cannot establish control over their own lives and may encounter different types of abuse. Abuse and neglect of older adults are common at all social and economic levels of society. Elder abuse is a medical, social, cultural, economic, legal, ethical, and public health problem that can be shaped by morality, ideology, cultural status, educational characteristic, and daily life experience. Elder neglect includes depriving the older adults of basic needs such as food, drink, heating, medication, and medical device, and causing emotional and physical stress to the older adults by being reluctant or refusing to fulfill caregiving responsibilities. What is neglect? Active neglect is defined as unintentionally depriving the older adults of their vital needs. Passive neglect is defined as unintentional failure to meet the needs of older due to a lack of knowledge or experience. Examples: leaving the older adult alone for a long time, not helping with house cleaning, not giving medication, not taking medication checkups, not supporting nutrition, not feeding or overfeeding. Self-neglect is a failure to perform basic self-care tasks that threaten the health and safety of an older person. Also, it has various social, economic, and cultural backgrounds. Again, self-neglect is a chronic, hidden global public health and human rights problems that threaten the health and safety of all older people. And self-neglect can be intentional or unintentional. Self-neglect behavior is characterized by an older person's failure to meet basic needs, such as nutrition, personal hygiene, dressing, and not receiving the service they need, not managing their financial affairs, and not fulfilling their self-care needs. Neglect and nutrition. Nutrition, an important determinant of health. In a healthy aging process, older adults need to have a balanced and adequate diet to prevent and delay disease. Neglect and self-neglect toward the nutrition of elder adults can be led to excessive weight loss or gain, dehydration, poor oral hygiene, and problems with the digestive and excretory system. Malnutrition. We know nutrition, but malnutrition encompasses both overnutrition and undernutrition. Malnutrition in the old is reflected by either involuntary weight loss or low body mass index. However, hidden deficiency, such as micronutrient deficiency, are more difficult to assess and therefore frequently overlooked in the community level old. Malnutrition is common and may also contribute to the development of geriatric syndromes. Malnutrition in older adults can be recognized as a challenging health concern associated with not only increased mortality and morbidity, but also with physical decline, which has wide-ranged acute implications for activity of daily living and quality of life in general. In addition, some parameter to assess neglect, malnutrition, edema, recurrent infection, low-level albumin, and low-level iron binding capacity, and low-level cholesterol levels may be considered among the findings suspicious of neglect. A balanced and adequate diet provides the energy and all the necessary micronutrients. We know vitamins, minerals need to maintain metabolic process. Nutritional programs specific to older adults contribute to maintaining health and extending life expectancy and can prevent chronic disease as well as inhibit their progression. Therefore, dietary intervention is an effective tool to extend life and delay the onset of age-related pathologies. The fact that older adults and or informal caregiver do not know the characteristics of nutrition programs, cannot comply with the program, and cannot access the nutrient contained in the program, causes older individuals to be neglected in terms of nutrition. Preparing the diet of the older people to take excess calories increases the risk of age-related pathologies, promotes chronic inflammation, decreases the expression of protein related to DNA repair, removal of free radicals, and stress and accelerates the aging process. Calories restriction or inadequate and unbalanced intake of nutrients by older adults prevents them from combating age-related pathological conditions such as diabetes, obesity, cardiovascular disease, rheumatoid arthritis, and Alzheimer's disease, increases mortality rates and leads to adverse health effects, including anorexia, sarcopenia, like this. In Turkey, the absence of data on elder neglect in the web databases of the Ministry of Justice and the Forensic Medicine Institution, the Turkish Institution of Statistics and the Minister of Health is an important obstacle in determining the extent of the issue and obtain clear results. As in many parts of the world, there are various studies conducted by scientists in Turkey on elder neglect. In this study, it has been determined that wide range, 5 5 or 80% older adults are neglected. There are empirical studies evaluating the nutrition status of older person. It has been determined that approximately 5 or 55 of older individual are at risk malnutrition. On the other hand, there is no data that older people with malnutrition and those at risk of malnutrition are victims or neglect or self-neglect. The research conducted to determine the relationship between older adults' nutrition and neglect or self-neglect, and to reveal the extent of the problem is not sufficient in terms of frequency and prevalence. The conditions and variables that cause abuse and neglect are not presented concentratedly. Therefore, research aimed at obtained empirical data and subject should be conducted more frequently and rapidly by expanding the scope of time, space, and taking in account the rate of increase in the older population. Conclusion: malnutrition is defined, which define a dimension of elder neglect. Therefore, I hope I will study malnutrition and elder neglect. Thank you so much for listening to me.
Ma'am, thank you so much for your wonderful presentation within a time
Thank you.
limit. Exactly, you have completed on time. Thank you so much, ma'am, for
Thank
your
you.
empirical
Thank you so much, everyone.
So now, before I move to the closing session, I request Dr. Amarendra Mahabhadra sir to give your views, and based on we can go for a closing of the session. Please, sir. And sir, can we open it session for the discussion few minutes? Dr. Mahabhadra sir, please. Yeah. So now the session is open for the discussion and clarifications. We have a very short time. I request the participant to have your observations and clarifications. So from the presenters, there is a four paper has been presented, and it's very good, very interesting and empirical presentations by the four expert speakers in the area of elder abuse. And I request the participants to have your clarifications, and followed by we can go for the closing of the technical session one. Please. Now the session is open for the clarification.
I suggest you ask them to put it in the chat box and let the speakers respond in the chat box, please, and let the closing comments be made.
Yeah, that also fine,
Okay.
madam. Yeah, fine. If
Yeah.
you say that, yes.
Thank you. Thank you.
I request, Dr. Mahabhadra sir is there? Sir?
That is there in the meeting, but I think he is not unmuted.
Okay, yeah. Sir, okay. No, it's not unmuted means even video also is muted. Yeah, good. So fine, but in the meantime that I can go ahead with my observations as for the closing of the session. And as for the technical...
Sir is back, sir.
Yes, sir.
Yeah, I had a nice experience today.
Yeah, please, sir.
Listening to an international webinar organized so nicely, and Professor Kapoor and the secretary and yourself, and the admin have well managed it within the time. And our speakers from international speakers have spoken within the limits of time and the knowledge. And there was many things to learn for me at least, and others also should similarly, if they have any queries, they should put it in the chat box, and I request all the speakers to respond in the chat box so that it will be easy for us to handle. And we have a next session ahead. So I congratulate all of you and thanks. Tamil. Tamil is some.
Yeah, thank you very
thank
much.
you. Thank you so much.
Appreciate it.
Thank you so much, sir, for your kind observations and empirical observation on the talk. Shall I take a minute to be summarize the sessions until we go for conclusions? Technical session 1 with the theme of elder abuse, a crisis and combating strategies, and with the sessions and myself and being as a chair and co-chair by Dr. Amarendra Mahabhadra sir. And there were 7 speakers has been submitted the paper expert talk in this session. But there is only 4 presentation has been made and 3 unable to join due to their technical glitches they had. And the first speaker who has spoken on that elder abuse in Indonesia, a silent crisis, and it's by the Daniel Augustine. Daniel Augustine is a wonderful paper with an empirical data from the perspectives of Indonesians, what the current crisis is there with regards to how the associations explain about the types of abuse, risk factor, and very particularly telling about it, how sociologically relevant risk factor related to individual factor, physical, mental, and dependency, social isolations, that what you call that, how it's more important as for the part to be noted down by the sociologists and health experts in the field. And she also mentioned about it and how this abuse, a lifespan approach taken to the account by the Indonesia in the mental health and mental health concepts and evidence-based practices and Indonesia being vibrant. And her paper also advised about it, government and community-based preventive measures. Its wholeheartedly is working in a way to be promote and prevent the elder abuse in the Indonesian soil. So thank you for her presentation. The second speaker, and it's by the topic elder abuse of development of elder abuse perspectives services in Taiwan. Actually, this paper is another interesting paper with an empirical fact by the Professor Paisan Young. She has explained about that special abuse category. For example, how the abuses take place with the low-income families and dependencies, and elder abuse occurred. He is telling about it more families being pinpointed as institutions where the abuses take place as for the part. And she also suggested the interventions, however, public education in all ages and in Taiwan, which being as instrumental to be intervened the issues of elder abuse. Also, she is studying about it. National hotline services will also be vibrant in this age. She's also been brought out with the ideas of how lack of understanding of the awareness and with regards to the abuse, neglect, and older persons, physical, mental, and cultural challenges also with the different dimensions. For example, the family abuse, drug and alcoholism, mental, and all these things that she also stated. She also has mentioned about the important point with regards to the social exclusion and the usage of AI, artificial intelligence by the Taiwan. And in the case of assessment of elder abuse cases, elder abuse preventions in the Taiwan strategies is a very wonderful presentation with an empirical fact. The third presenter, that is by our esteemed professor, Professor Jayashree ma'am, and from the Kannada University, says wonderful papers related with the elder abuse, contemporary issues and policies. And actually, ma'am has been highlighted with the policy perspectives and how India is working with regards to the policy perspectives with regards to the gender abuse, elder abuse is being concerned. Ma'am also has been pointed out that how the feminization of elder abuse is a very important dimension. I feel that in the elder abuse scenarios being taken to the account. And ma'am also stating about institutional abuse and how the domestic abuse, institutional abuse, and the categorizations. And that's too related with which areas the abuses take place. For example, property related, wealth related, and the financial related, cultural. And as ma'am is also stating about it, how the son and daughter-in-law, and they have a different stakeholders with regards to the abuse is being concerned. And I too had a query to ask with the ma'am, what about the mother-in-law, whether she has any role with this abuse or not? And only son and daughter-in-law is being making a role in this part of the part. Ma'am has been highlighted how it's been related with the financial related son and food related, other service related, which by the daughter-in-law women, the education related go ahead with that. Ma'am concluded with the educate the elderly and emerging centers for these dimensions. The final speaker of the technical sessions 1 is by the Dr. Serian. Is from the Turkey. Her paper related with the malnutrition in the older adults and neglect. Very important area, madam. Actually, while we are talking about the gerontology, that is the only reason I appreciate the organizer, Professor Mala Kaburda Sangardas ma'am and Professor Prabhakar is. So why the RCTWAL is placing a vital role here? Because gender, gerontology, health is inevitable to be inseparable as far as the part is being concerned. So while we are discussing about gerontology, that's important. It's a mandate to be discussed about the malnutrition in the older and the adult and neglects area also. And very importantly, your paper has been highlighted in this area. It's a very important study area, madam. Actually, you have been given an input for me really is eye-opening to think of it and malnutrition dimensions of the challenges and health concern, how it leads to the increasing mortality among the olders and formal, informal caregivers, how it's being there and age-related health problems and need for empirical studies emphasize that you have given. Thank you so much. And on behalf of my co-chair and beloved our doctor, the scientist, Dr. Amarendra Mahaputra sir, and on behalf of the organizing secretary, I thank each and every one of the presenters and those who have participated in this technical session 1. Thank you so much, madam. Once again, thank the organizers for being given me an opportunity to be part of this technical session 1 as a chair. Thank you so much.
Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you. So we will move on to the next session. I request Professor Manushi and Dr. Balamurugan to take over.
Very good afternoon, sir.
Good afternoon, ma'am.
And thanks for giving me this beautiful opportunity to chair the technical session 2. And hello, sir. And well done, sir. You have very well coordinated first technical session. Very good afternoon to Mala ma'am also. And Dr. Balamurugan, sir, must be with me, I think.
Yeah, he's there.
So, okay, sir. So, Dr. Prabhakar, should I start?
Yeah, please start, ma'am.
Okay, sir. Thank you, sir. So, it's a pride privilege for me to welcome all respected dignitaries, experts, faculty participants, and student participants in the second technical session on the theme of concerns related to abuse, healthcare, and wellness. So very good afternoon, esteemed colleagues and participants. As we have assembled today to mark World Elder Abuse Day and the International Day of Older Person, we confront a significant and urgent issue of elder abuse. This challenge a critical intersection of public health and well-being, which demands our focused attention and collective action. And elder abuse is not merely a series of isolated incidents, but a profound public health crisis that impacts the core of communities. It manifests in many forms: physical, emotional, financial, and neglect, and affects millions of older individuals globally. The complexity of this issue is intertwined with broader concerns of healthcare and wellness, as it directly influences the quality of life and overall health of our elder population. In our discussion today, we explore how systemic factors contribute to this problem, including gaps in healthcare, socioeconomic conditions, and societal attitudes towards aging. Understanding these dynamics is crucial for developing effective interventions and policies that can safeguard the dignity and well-being of older persons. Our role as sociologists is to scrutinize these issues thoroughly and rigorously, and rigorous research and engagement in finding out the solution is very important at our level. By examining the root causes of elder abuse and its impact on healthcare system, as well as on wellness, we can advocate for meaningful reforms and support structures that address the healthcare needs of the elderly. So let us approach today's conversation with a commitment to uncovering solutions of fostering a society where every older individual can live free from any fear and abuse. Your insights and contributions are vital as we work together to advance this critical agenda. Thank you for your dedication. So I welcome our first speaker of technical session 2, Dr. Elham, researcher and lecturer at Goldston University Medical Sciences, Gorgan, Iran. So I welcome, ma'am. It's a privilege for us to hear you.
Thank you. I'm so happy I'm here and present this project on behalf of Aging Research Institute, Tabriz University of Medical Sciences. And I'm researcher and lecturer at Golestan University. The project that I want to present here is about assessing the adaptability and implementation of the Respite care intervention program for semi-independent older adults in Iran's care service system, a pilot study. As you know, the many older adults gradually lose their independence in performing many daily activities because of their disease and psychological and physical dysfunction in the process of aging. And so they rely on informal caregivers who are mostly their family caregivers, and in Iran. And for family caregivers, doing some caregiving tasks and demands of elderly people can increase care burden among these people, and leading to physical and psychological fatigue. And the caregivers may confront many problems, and such as physical and psychological fatigue, and they are more likely to conduct abusive behavior against their older adults. So in this project, we are going to create and design the model, respite care model, as a common model in the and as you know, the respite model as a common model in developed countries. And this model provides great opportunities for families and family members to recover their energy and find the rest. And the aim of this project is to implement respite care for semi-independent older adults by master students in geriatric health in order to promote the health of caregivers and elderly. In Iranian society, specialist case care services are not specifically designed for older people. And so implementing a respite care program run by geriatric health students and could help them provide free expert care to elderly individuals and their families members. So this model will help students to gain valuable opportunities to learn how to communicate with older adults and in educational settings. So the result of this research can play an important role in developing protocol for geriatric health student internship. The specific objectives of this project, we classified them into two outcomes. The first outcomes, we will consider the caregivers' burden among informal caregivers, depression among informal caregivers, and also we will assess the elder abuse among older adults, depression, and social support among caregivers and as well. For secondary outcome, we will check and assess the attitude of students, geriatric health students, among the attitude towards the aging students before and after intervention. And also we will do assessment of the students' ability before and after the intervention. In inclusion criteria, we will consider all the participants who are willing to participate in this study. Older adults who age 60 and above, and they're referring to health center, and they should be semi-independent and using Bartel index. And older adults shouldn't have any acute illness, such as physical or mental, that they requiring hospitalization or special medical or nursing care. And this older adults shouldn't suffer from the severe cognitive impairment based on the AMT. And for caregivers, so assessing the burden of caregiver, we will assess them based on the questionnaires and the caregiver burden questionnaires and the skill, and they should be more than 40. And the master students in geriatric health should have tendency to participate in this intervention. And the last criteria inclusion that we will consider, residents of the older adult and the caregivers and the students should be residents of Tehran city or present in the city during the implementation of this project. And for method and material, we will. This project is the multiple method study that will be conducted in 3 phases. In the first phase is we will do literature review, and the second one we will assess the need assessment of the caregivers and older adults, and the third one we will do pilot clinical trial study. In the first phase, we will do literature review, and through the rapid literature review and the component of the respite care for older adults in other countries will be extracted. And we will search through some databases such as PubMed, MS, Scopus, and Sinahol, and we will search, and the keyword that we will use are respite care, family informal care, center-based respite care, caregivers, their respite centers, older adults and students, and respite provider. After and also the researcher will take advantage of a great literature available to our researcher and the components, so that they can gather the component of the respite care, which may be the type of respite services provided in centers, long-term and short-term, service delivery time, and other components. And all this information will be extracted and entered in the data extraction table prepared by research team. For the second phase, to understand the needs of the caregivers and older adult in cultural context of Iran, and the researcher will assess their preferences for respite care services. So an open-ended questionnaire will be designed to investigate the preferences of older adult and caregivers regarding the type of required care services. In this, through using these open-ended questions, the older adult, the researcher will be asked about the older adult preferences and their caregiver. This question, when we will consider 6 questions, and the first question is when we will ask them, as someone who cares about older adult, what care services do your older adult need during the care? And we will this question, the caregiver, family caregiver. And the second question says, as someone who cares about the older adult, what care services do you think can be provided to older adult in case of your absence? The third question, as someone who cares about older adult, when do you need to take care of your older adult, and at what time? And the fourth question, what care services older adult need during the day? By this I mean the care services that your family is not able to provide for you, and what care services do you need when your family members are away? And actually we will ask these questions for older adults and their caregivers, and because we want to understand about the older adult preferences and their caregivers' preferences. And the fifth questions, as someone who receives care services, where would you like to receive these services? Home, daycare, nursing home, and others. And also will ask, as someone who cares about the older adult, where would you like your older adults receive these care services? Home, daycare, nursing home, and other places. The result from literature review and the open-ended questions that we designed, this material will be used to adopt the Respite care program for semi-independent older adult, and which will be implemented in the third phase of the study. For the third phase of the study, a pilot clinical trial study will be conducted on the Respite care program for semi-independent older adult by master student in geriatric care. Actually, the research team will compile a list of master students interested in participating in the intervention program at Tehran University. An orientation meeting will be held for these students, and where in this meeting, the objective and all component of Respite care program, along with detailed implementation process, will be explained. And based on the conducted studies and the literature review, acceptable sample size for pilot studies is at least 30 participants, and therefore we will use 30 in a semi-independent older adult who meets the inclusion criteria. And based on internship program curriculum of the geriatric health students, each student will be responsible for the care of 5 older adults, considering that calculated sample size 6 students will be recruited for these pilot studies. And all eligible older adult and caregiver will be invited to the briefing. Pardon me?
Last minute. One more minute, ma'am. This is the last minute, please, ma'am.
Okay, I will finish it. All eligible older adult caregiver will be invited to briefing at a specific time, and this may be selected by the Tehran University and their authorities. And master student will be conducted this respite care for twice a week for 12 weeks from 9 to 12 p.m. 9 a.m. to 12 p.m. And also, a student will keep the record of the care provided based on an adopted care program for semi-independent older adult and submit it to researching. And I should say that the questionnaires that we want to, some variable we want to assess, we will fill this questionnaire at the beginning before the start our intervention program, and after the intervention program we will complete that questionnaires to understand to evaluate and understand the effectiveness of the respite care intervention program, and so understand how this intervention can affect on elder abuse and other components that we consider about it. And thank you for your listening.
Thank you, ma'am, for your elaborative explanation about the project that you did on a very relevant and concerned topic of our webinar.
Thank you.
Thank you once again.
Thank you. Thank you. Thank you so much.
So now I'm going to invite the second speaker, and I'm really feeling very privileged to invite Professor Azra Abidi, ma'am, Head Department of Sociology, Jamia Millia Islamia, Central University, New Delhi, and she is going to address on the topic Adversity and Adaptation, a sociological study of elderly people living with ailments in conflict zones. Welcome, ma'am.
Thank you so much. Thank you. Good afternoon, everyone. First of all, I express my gratitude and thanks to all the members of ISS RSC 12 and organizing committee for providing me this opportunity to share my views in today's international webinar. The topic of my presentation is Adversity and Adaptation, a sociological study of elderly peoples living with ailments in conflict zones. My focus is sociological dimensions of how elderly people living in conflict zones endure not only the physical and psychological toll, but also demonstrate remarkable adaptability to these harsh conditions, despite inadequate medical and social support. Elderly people in conflict zone face unique and profound adversities, often becoming some of the most vulnerable in crisis situations. With limited mobility, deteriorating health, and diminished access to essential resources like food, medical facilities, medical care, and shelter, they struggle to survive in environment of violence and instability. The breakdown of social and familial support system exacerbates their isolation, leaving them at heightened risk of neglect, abuse, and exploitation. Additionally, the psychological toll of conflict coupled with the trauma of displacement or loss of loved ones. As a social scientist, discussing this issue is crucial because it highlights a demographic often marginalized in conflict discourse. Understanding the specific challenges elderly people face allow for more inclusive policies and interventions that address their needs, ensuring humanitarian responses are equitable. It also brings attention to the intersection of age, conflict, and social systems, fostering a deeper understanding of how societal structures impact vulnerable populations during crisis. Bush and Duggan in 2013 conceptualized conflict zone as environments that are unstable, unpredictable, and challenging to study. These zones not only characterized by military violence, but also by non-militarized forms of violence, such as gender, caste, class, and political violence, bring forward a range of issues that make the evaluation of condition in conflict zones methodologically and ethically complex. Defining elderly and living with ailments. In terms of defining who qualifies as elderly, this presentation follows conventional benchmark, but also introduces the concept of frailty. Rockwood and others in 2000 describe frailty as a condition that increases vulnerability to disability and death, making it a more comprehensive measure than simply age. Importantly, frailty does not necessarily coincide with disability, along they often overlap. The concept of living with an ailment extends beyond a straightforward diagnosis. It encapsulates both real and perceived illness, including conditions similar to hypochondriasis, where individuals believe they suffer from undiagnosed physical ailments. However, this belief can be rooted in psychological or social stressors, particularly for those living in a conflict zone. The intersection of conflict and health. Living in conflict zone exacerbates both physical and mental health issues among the elderly. Prolonged exposure to violence, displacement, and loss can lead to psychological conditions such as PTSD, anxiety, and depression. These stresses can worsen perceived ailments, leading individuals to misinterpret normal aging processes or mild symptoms as severe illnesses. The chronic anxiety, social isolation, and disruption of support systems common in conflict zone allow such health anxieties to flourish. This creates a cyclical pattern where psychological and emotional distress heighten physical symptoms, creating what is referred to as illness anxiety disorder. Addressing the root social causes such as improving living conditions and rebuilding social support system is key to alleviating these ailments. Adaptation in conflict zone. Despite these immense challenges, elderly individuals in conflict zone find ways to adapt. They often engage in storytelling, using it as a way to preserve their histories and share their experiences with others. Traditional healthcare practices such as the use of herbal remedies are another means of coping. Family and community gatherings provide essential social and emotional support, helping them withstand the harsh realities of their environment. However, while these adaptive behaviors are remarkable, they are not sufficient to address the underlying challenges these individuals face. It is here that policy intervention becomes crucial. In conclusion, I can mention here the important aspect of my presentation that an exploration of these forms of living with ailment allow us contextualize illness among the elderly people living in conflict zones. In doing so, we can also ascertain how social isolation, witnessing of a traumatic event, stressful environment, neglect, among other variables may factor in the constitution of illness. Elderly individuals in conflict zones may therefore face a dual burden of managing their chronic illness while also coping with the severe psychological and emotional effects of living in a conflict zones. Here, we can also witness a development of a causal loop wherein one condition feeds the other. A sociological exploration of living with an ailment takes into account the discourse from the sociology of medicine, which inform us of how social situatedness of elderly people corresponds to their perceived feelings of illness. This perceived notion of ailment may or not correspond to medically diagnosable disease. However, the relationship between social factors and illness in a sociological exploration of ailment constitute an axiomatic essence in which it would be improbable to explore ailment without realizing how various social factors may act as agent of illness. To effectively address this critical issue, targeted intervention must be tailored to the specific needs of this population. Policy intervention is crucial to address the systematic and structural factors. It is through such intervention that we can create a comprehensive and sustainable approach which ensures establishing protocols for identifying, reporting, and responding to the needs of the elderly population. Understanding the concept of living with an ailment among elderly individuals in conflict zone is crucial for developing effective policies aimed at reducing conflict and addressing the unique challenges faced by them. The relationship between conflict, stress, and health outcomes for the elderly provides a framework for policy making that focuses on both reducing conflict and improving the social and healthcare environment for elderly populations. It is by integrating both medical and sociological perspective that we can better understand the unique challenges faced by elderly people in conflict zones and devise more effective strategy to support their health and well-being. So this is the summary of my presentation. I have given an understanding to all the participants, to all the audience, to understand in a conflict zone how elderly people face different kinds of challenges. It may be social, it may be cultural, or it may be sometimes medical. So we need a comprehensive approach. There is a need to develop a comprehensive approach to understand elderly people, particularly who lived in a conflict zone. So thank you so much for your valuable time.
Thank
you
you
so much, ma'am.
Thanks a lot for your very interesting session on a very relevant topic and very important on which we have to think about to improve the conditions of and situations of elderly people living with ailments. Thank you, ma'am, once again. And now it's a great privilege for me to invite our third respected speaker, Dr. Sudeshna Mukherjee, Associate Professor, Center for Women's Studies, Bangalore University, India. I welcome you, ma'am.
Thank you. Thank you, Professor Srivastava. So, shall I share my presentation, or it will be automatically be shared, because I have already shared with the organizers?
Dr. Balamurgan, sir.
Ma'am,
Yes,
ma'am,
we
I
have
will
it.
make you the co-host. You can present, ma'am.
Okay, okay, 1 minute.
Because, yeah.
No, it is not giving, I cannot share, it is showing.
Yeah, now you'll be.
Okay.
So, my presentation is visible?
Yes, ma'am.
Yes, ma'am.
You can see.
Yes,
So,
ma'am.
shall I continue? So,
Yeah, you can
respected
make
chair and co-chair and
make it full screen, ma'am, please.
yeah, sure, sure. Yeah. So I think you can see it now, no?
Yes, ma'am.
Yeah. So respected chair and co-chair, and my sincere thanks to Professor Mala Kapoor Sankardas and Professor Prabhakar for organizing such a meaningful and thought-provoking seminar for all of us. So my topic is about the demographic dividend and the demographic, demographic dividend to demographic challenge. So we know that India's demographic transition has long been marked by the potential for a demographic dividend. So where working age population exists the dependence and fostering the economic growth. So we were hoping that our younger population will bring a lot of growth and prosperity, but at the same times, we are facing another challenge which we are quite oblivious of, that our elder population is rapidly growing, and it is approaching to a stage where we can call it a demographic burden stage, when our population aged 60 and above is projected to rise to over 300 million by 2050, which will be according to the 20% of our population. And we see that a significant policy gap in this area, where we still, that elderly care or elder perspective is still mostly we are relying on the families. So now we see that why we need that growing need of geriatric care. There is one thing is that the lifespans are increasing. At the same times, there are the chronic diseases. Aging is often accompanied by chronic diseases such as heart disease, diabetes. And if you see that those who are suffering from dementia and Alzheimer's, those kind of conditions, they require specialized care and support. And at the same times, when it is coming to the caregiving, we see this still, the caregiving part is, we sincerely depend on our family structure, which is fast changing with increasing nuclearization of the families and migration. And especially you can see that both the persons, like especially the working status of the woman, that brought a significant change in the care dimensions, because so far we thought that unpaid unconditional caregiving is typically the woman's job, and when women are going out for the work, that void is created. We have not created any support mechanisms to fill that gap. So you see that in this context, that growing need of elderly care and the gap, that is one of the reasons. I mean, we have from the morning we have been discussing about the elder abuse issues. So this is one of the major reasons for the elder abuse. So elder abuse, it is a global issue, and if you see that data from a 2020 longitudinal study, which is showing that the percentage of elder abuse is 5.22% in India. So apparently, in terms of global percentage, it is less. Globally, it is every 1 in 6 elder adults are facing abuse. But we have to keep this in mind, that these statistics we are talking in terms of reported data. In previous session, Jai Shri ma'am was talking about that how we feel ashamed of bringing these private issues to the public. So often elder adults, they face this abuse and they bear it, they don't bring it, or they don't think of reporting it. So therefore, whatever we are, the number we are seeing, that is tip of the iceberg. So in my presentation, I'm focusing more on the women elderlies, because the abuse, if you see the reasons of abuse, there are very, very interesting, like one of our studies showing that when women are abused, you see that women are abused, those who have got greater household assets, they are abused. So you cannot see that only poor are being abused. Those who are of the poorer health, they are abused because of this healthcare need, care demands and all. Then you will see that working older adults. So those people who are from the poorer section of the society, who has got no social security benefit and who has to work to support themselves even in the when they are very elder, that time also they are victim of ageism because of their slowness and all these things. That is quite natural with the age, but they are abused, they are victimized in their respective workplace. Then the women who are single, those who are not in the marital union, their propensity of getting abused are more higher, because still again the marriage and subsequent having children and all, that giving you some kind of a social security in the absence of a larger network of the social security. And then you see that those who are in the rural areas, they are deprived of access to healthcare, medicine, many other facilities. So they are also, the propensities of getting abused are much higher. So if you see that prevalence of the elder abuse in India, that we say that even there is a state-wise dimension of the elder abuse. So you can see that among the Indian states, that my next slide will show you that Bihar is supposed to be the highest in terms of reported cases. This is one of the study done by the Population and Aging Springer Net Journal. So from there, this is a 2022 article which is talking about this, that state-wise Bihar is highest in terms of reported elder abuse, and Karnataka is second. And you can see that the northeastern states are much lesser in terms of the reported older abuse cases. And if you see that, very interestingly, when we look at the state statistics, we will see that in every state, women are more abused than the men. And if you look at the types of abuse, you can see that 14% respondents say that they suffered frequent abuse, while 52.83% respondents say that they experienced occasional mistreatment. Verbal abuse is the most common form, and you can see that that is reported by 93.33% persons, and following by the neglect, and then the emotional abuse. Then you have that economic abuse. So you can see that this economic abuse, there are two. In economic abuse now, one is that your poverty-stricken condition, unable to access resources. That is definitely one of the reasons, dependent status. And that's why you can see that women are more in abusive conditions, or in a family status. But very interestingly, you can see that now technology is also becoming a means of abuse. Now we have seen that there is a significant technologization of the society, where we are depending internet, especially the internet facilities, for accessing so many benefits, booking doctors, booking vehicle, purchasing your grocery. And here elders are facing significant, you can see that, challenges because of the technological divide. And this is also becoming a significant means of victimhood. If you can see that this online frauds and these kind of issues globally, and also in India, the majority, a significant number of victims are from the elders. So if you look at the perpetrators, again, even my previous presenters are also presented in that way, that family became the main source, because family is only who are providing care, and these care conflicts are happening. So here you can see that the position of the different states, like how these things are showing that Bihar as the highest, and every state, this orange is signifying the woman and blue is for the men. And you see that in most of the state, it is the women who are in the most abusive condition. So now you see that what are the contributing factors as a sociologist? If I look into the theoretical perspective, you see that social learning theory, which was talking about that violence is a learned behavior. So elders also too have contribution in their own violation. If a son grow up showing that father is repeatedly abusing mother, so once, I mean, we have come across, I have in my studies come across the families where son is feeling no remorse in abusing father because he is openly telling that I have seen this man abusing my mother. So it is a learned behavior. So people learn this. I mean, it is passed down from generations to generations. Then in social exchange theory, if you can see that elder abuse can occur due to a cycle of dependence, which I have kept on telling you that economic dependence, and especially you can see that we have that absence of definite pension system. So don't think about, I mean, especially in the economics terms, the missing middle, that is also a very significant, because affluent section, they have some kind of a social security net, they have covered themselves. Whereas for the poor, there are certain kind of a social security available, though that is very meager, that is not sufficient, but in the name that is there. But for the middle section, they have nothing. They have not gathered money and they have not have enough. So that section is also facing significant, challenges and the abuse. The feminist perspectives say that, again, that it is a patriarchal family structure, subordinate dependent position of the woman. So that leads to the feminization of abuse. When we look at the elderly abuse, there is a significant feminization trend. And then a psychopathology of the caregiver, which talks about that how the abuser's characteristics contributes to the abuse. So if your caregiver is having dependence, I mean, suffering from depression, anxiety, or if he has any kind of an intoxication, drinking or drug, so that also collaborate in increasing the abuse. Then you see that what are the policy challenges, what are the policy gaps we are feeling that, which also increasing the elder abuse in the country, that lack of comprehensive geriatric health infrastructure. If you go to the public hospitals, how many public hospitals has got the geriatric care unit? This is not there. So, I mean, that specialized care, that specialized support, it is not there. Forget about rural areas. Even in the urban areas, this is not there. Then we have that absence of sustainable social security system. India lacks a robust pension system that covers a large segment of the elderly population. A significant portions of the Indian elders work in the informal sector. So they are outside the purview of the any kind of a pension system. Now we have systems, as I say, that we have still the problem of the missing middle. Then mental health services gap. So mental health issues like, depression and other issues like dementia or Alzheimer's. Pardon? Pardon?
Almost time over.
Okay, sure. I'll just finish. So you can see that these are the inadequate implementations of the national program and insufficient the long-term care. So we don't have adequate old age homes and the care systems, rehabilitation for the woman, which also, increases the abuse. So we can see that the shift from the demographic dividend to demographic burden is an inevitable phase for any country. In India, policymakers must address the glaring gap in geriatric care to ensure elderly population does not become marginalized and to maintain the socio-economic stability of the country. The ability to care for its elderly will be the defining factor in navigating this demographic transition effectively. Thank you.
Thank you, ma'am, for your very elaborative session on how we can address the challenges that we are facing nowadays related to elder issues and elder problems, where women are becoming more victimized as compared to their male counterparts. Thank you, ma'am. Now I'm going to invite the fourth speaker, Dr. Ho Mau Wai, Principal Mentor, Empowerment Mentors, and he is going to deliver his session on caring for our elders, legal frameworks, and combating abuse under the Maintenance of Parents Act in Singapore. Welcome, sir.
Thank you very much. Thank you. Just a moment. I will be sharing my slides. Just a moment. Okay, let me just share my slides. And then I will share. Can you see my screen?
Yes, sir. Visible, sir.
Thank you very much. Good afternoon, ladies and gentlemen. Thank you for having me. My name is Homan Wai. I'm going to share something about practices in
Sir,
Singapore.
please keep your slides on full screen.
Yes.
Excuse me, sir. Sir, please keep it on full screen. Thank you, sir.
Yeah. Okay. Just a bit of introduction of myself. I'm not exactly a researcher or an expert in this area. My background is in education. I used to work in the NUS School of Medicine, in a polytechnic, and also in the United Arab Emirates. My specialty is in policy development, particularly in the sport management and sport coaching area. And recently, in more recent years, due to the changing demographics, my practice for sport also ventured into sport coaching for the elderly. And that's why I ventured into this area. And the other area of my interest is in mediation and arbitration, where I'm a fellow of the Singapore Institute of Arbitrators, and I have developed the alternative dispute resolution framework for the sports industry in Singapore. And that's my interest in sharing with you about the Maintenance of Parents Act. Okay, first of all, this question, the problem trigger, the big question about abandoned aged parents, parents who are abandoned. So whose responsibility it is? That's a big question. Now, gathered among here, this big group, esteemed group of speakers, we have economists, we have sociologists. So the economists will ask, is it the government's responsibility? Meaning to say, should the government pay for it and raise taxes to pay for it? Or is it the role of the charities where people should go to the people to fundraise? And in either way, there's this question about sustainability. And of course, there's another question sociology will ask, well, shouldn't it be the responsibility of the family, the children, the extended family? But we all know that the world is not perfect. There's this thing about market failure where what is intended naturally didn't take place. So what do we do? What is the intervention? First off, moral suasion. We persuade, we educate, we create awareness. But what if that fails? What further measure can be taken? And that's where we resort to thinking about laws, legislations. And this morning, we have Dr. Ng Chong Wai. He was sharing with you on the left-hand side of the screen the few related laws in Singapore that has been enacted. And I'm going to focus in particular on this particular law, Maintenance of the Parents Act. And as Dr. Ng was sharing this morning, when it was first introduced, naturally there's a lot of controversy. But finally, it was passed in 1995 and went through 2 cycles of amendments in 2010 and 2023. Now let's talk about what is the purpose of this law. It is to provide a safety net for the needy and neglected parents. Support parents who are unable to support themselves. This can be in the form of lump sum payment, regular payments, and medical expenses. Now let me just bring ourselves to the context of Singapore. Singapore is a city-state. It's a city, it's an urban area. When you talk about care for the parents, especially if there are no caregiver at home, a lot of these, invariably, the solution becomes institutional care. When institutional care is concerned, lots of money is involved, right? So that's where there's this requirement. But as in any law, it may be misused. So there are eligibility criteria. The first thing is age, meaning to say specifically 60 and above. Now, there's this second question, and this issue was dealt with in the subsequent amendments of the law. What if the parents who are being neglected now will themselves have records of abandoning their children or abusing the children in the earlier years? Can they proceed with a claim now against their children? So the subsequent amendments of the law has addressed this. The answer is cannot. And the third question is, the third criteria is that children must be able to afford, but did not do so. Then the law can be leveraged upon for the parents to seek their maintenance. And a fourth purpose is to strengthen family bonds. Hopefully, this will help to bring children and family and parents together. Now, of course, I'm sure in your various countries, you have similar provisions. The question is this too acrimonious to expect parents to sue their children? It may seem so, but here's the beauty of it, that measures have been taken, designed within the provisions of these regulations, so that it is not just about suing. There is a pathway of escalation, right? In the first instance, there's a conciliation, meaning to say, we bring people together, parents and children are brought together to have a talk, and hopefully cases can be resolved at that point in time. In my experience in the other sector, which is dispute resolution for sports, a lot of the cases can be settled at this point. If this fails, then you go on to the next step, mediation. But mediation in our context, in the legal context, is not just bringing people to talk together and negotiate. It is not. There's a mediator. The mediator, under the provisions of the law, can play an active role to persuade parties to come together towards a solution, right? But this sort of mediation, is it enforceable, right? That's a big question. It is not enforceable. It can be, people can walk away from the mediation, walk out of mediation, and renege on the agreement is possible. So the way to ensure that it is enforceable is that there should be an agreement, right? So subsequently, if parties renege on the agreement, then it becomes a breach of contract, then you can sue under the contract law. Now, if mediation fails, then you go to the final step, which is filing a claim to the tribunal. Now, the tribunal acts as the court under the Maintenance of Parents Act. The tribunal, the president, and the three tribunal members will have the authority to decide. So they act as judges. They'll listen to the cases and then they will arrive at an award, meaning to say that they will determine whether the claim is successful or not and the quantum of the claim. What's the situation on the ground? Well, we are a country of about 6 million people. And these are the statistics in terms of the elderly abuse cases: high risk, moderate risk, low risk, in the hundreds. These set of numbers in terms of the Maintenance of Parents Act is a bit dated, but it gives the order of magnitude. It is being used, it is being leveraged upon. So every year you have about 200 cases. So what's the challenges, the lesson learned, and potential to move forward? The law has been enacted since 1996, so it has been almost 30 years. As you can see, has it been useful? It has been useful. About 100 over cases are filed every year. Now, what are the unintended side effects? The hope is that the law will bring people together, bring families together. But has it improved or aggravated ties? And the third point that we should also monitor is the support systems for the application process. Elderly, if they reach this stage where they need to leverage on the law to file a claim, the situation will be very, very challenging already. So most likely the elderly will need the support of an external party to help them with the process. And there's where potentially what is the role of charity, the non-government organization, the pro bono legal services who may be able to offer the support system. And finally, is for us to continue research and public policy discussions, and potentially to look into some of these parameters for a cross-country comparison in order to continue to find approaches that we can have regulations and laws, but not so much in the hope that we will have less need to activate, to use the laws to resolve cases. The laws will serve as a deterrent rather than and a last resort, rather than have to be a measurement of the first instance to resolve differences. That's all I have. Thank you very much.
Thanks a lot, sir. It's really a great pleasure to hear you, sir. It's very enlightening and a new area to think about it and to ponder about it and to implement the acts that can protect the as well as financial of neglected parents. So it's really a great pleasure, sir. Thank you, sir.
Thank you.
So now I'm going to invite the next speaker, Dr. N.B. Valpita, MBBS and MSc Community Medicine, Registrar in Community Medicine, Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. So I welcome your area of talk is an approach to address elder abuse in Sri Lanka. Welcome, sir.
Thank you very much, Chair and Co-Chair. And I would like to give my sincere thanks for inviting me to deliver a talk in this very important webinar. So let me share my screen. Can I please share the screen?
Pardon me, Kirtana?
Sorry, madam.
Kirtana, are you there? Hello?
Okay, hope you can see my screen.
Yes, ma'am. Yes, ma'am. You can.
Okay, thank you. So today I will be talking about an approach to address elder abuse in Sri Lanka. So this will be the outline of my presentation. Sri Lanka and aging, elder abuse in Sri Lanka, approach to address elder abuse, and challenges and way forward. So this is a bit about Sri Lanka. Sri Lanka is an island in the Asian continent, and it has 9 provinces and 25 administrative districts, and we have a total population of 21 million. So if you move on to aging in Sri Lanka, an older person in Sri Lanka is a person who is 60 years and above, and it is a rapidly aging country in the Southeast Asian region. And according to the 2012 census, we had a 12.4% of the total population above 60 years. And by 2023, it was 16%. And by 2041, it is expected to be 25% of the total population. So by 2041, 1 in every 4 persons will be an older person. So with the increasing aging population, Sri Lanka is facing many health, social, and financial implications. When we move on to elder abuse, we do go by the WHO definition of elder abuse, which is considered as a single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust which causes harm or distress to an older person. And according to WHO estimates, 1 in every 6 person, that is 15.7 of people above 60 years and older, are subjected to abuse. So what are the types of elder abuse? They can be physical, sexual, emotional, neglect, abandonment, or financial. So when we move on to elder abuse in Sri Lanka, it is a public health problem in Sri Lanka, and it is also a social issue and also a health issue, because elder abuse can have many negative health impacts affecting the well-being of the older persons, and also it is a violation of the rights of the older person. And elder abuse is still a hidden and a silent topic in Sri Lanka, so we do not really know the real extent of the elder abuse. And prevalence of elder abuse is more common among older women. And if we take the older persons in Sri Lanka, they per se do not accept that they are victims of elder abuse. So we really do not know the real extent of elder abuse in Sri Lanka. So where does elder abuse take place? It can take place in many places like home, public places, community, and also in elderly homes. So if we take home, at the home setting, physical abuse, verbal abuse, and financial abuse can take place. And also in public places such as transportation facilities, health services, or any other service provision place, different forms of elder abuse takes place. And as all of us know, within institutionalized older persons, elder abuse is more prevalent. As a UN country, Sri Lanka is also always in par with the global agendas. So in facing the increasing challenges of the aging population, we have planned our strategies according to the Decade of Healthy Aging, which has 4 different areas: age-friendly environment, combating ageism, integrated care, and long-term care. Combating ageism has a direct connection with prevention of elder abuse, where we do have to change the attitudes and the stereotyping about aging. When approaching elder abuse, I should say that multi-stakeholders come into play, involving health sector, social sector, state sector, private sector, and also non-governmental organizations. And also older persons play a very important role, becoming a stakeholder in preventing elder abuse. So I would like to bring your attention according to these 4 strategies where we have approached in Sri Lanka to prevent elder abuse through legislation and policies, public education and knowledge sharing, empowering older persons, and capacity building. So if we move on to legislation and policies, in Sri Lanka, we do have a lot of legislations and policies which directly and indirectly address elder abuse. The Protection of the Rights of Elders Act number 9 of 2000, National Charter for Senior Citizens and National Policy for Elders 2006, and National Elderly Health Policy are some of the most important legislations and policies. So if we move on to the Protection of the Rights of Elders Act number 9 of 2000 is the main legislative document which covers the human health and social rights of elders. So any sort of elder abuse is a violation of elders' rights. So this is the main legislative document. Under this legislative document, we have formed the National Council for Elders. This is formed by the President of Sri Lanka, where it is represented by multi-stakeholders. And the National Secretariat for Elders is formed under this National Council, where they provide a lot of health, social services for the older person. So the ERPO, who is the Elderly Rights Promotion Officer, is the ground level officer who is attached to the divisional secretariat officers all over the island who have direct communication with the older persons in the community. So if any older person is subjected to elder abuse, they can contact their area elderly rights promotion officer and get the services and get connected with the available services. And I also have to mention about this maintenance board. This is coming under the purview of the National Council. So if any older person is subjected to abuse, they can directly complain this maintenance board, and then the authorities will be taking the necessary action after inquiry regarding the incident. So this is for the legislation and policies part. And in preventing elder abuse, it is very important that the public is made aware regarding elder abuse, regarding how elder abuse takes place and the types of elder abuse. It is very important. So we use a lot of means of mass media in increasing the awareness of elder abuse, and also it is very important that the younger generation is respecting the older persons. So about respecting older persons and about elder abuse is incorporated into our curriculums from preschool. And also recently, elder abuse is also a prioritized topic in scientific forums and research forums. Empowering older persons is very important because older persons are considered as a very important stakeholder. So making aware about the available legislations is very important, and upbringing intergenerational solidarity by upbringing the good connection among the older persons and the youth is very important. So these are done through elderly clubs and youth clubs. And also, as I mentioned earlier, preventing elder abuse should be done through multi-stakeholder involvement. So we have approached it through local, regional, and national levels with the cooperation of the private sector, non-governmental organizations, and donor agencies. And also the service providers should be sensitized on the importance of providing elderly friendly services. So capacity building programs are conducted for service providers in the state sector and the private sector. So these are some of the approaches that we are doing in Sri Lanka in prevention of elder abuse. So I would like to show you some activities that we have done during the past years. As we all know, during the COVID-19 pandemic, elder abuse prevalence was increased because of the isolation, and many older persons were restricted to their homes. So in Sri Lanka, many older persons and younger generation got the opportunity to spend more time in their homes. So we have asked the older persons and the younger generation to write essays on their personal experience about each other separately for the older persons and the younger generation. And we selected the best essays and published these 2 booklets during the COVID-19 pandemic. So this was an activity which was done to enhance intergenerational solidarity. And also, it is very important that the younger generations are sensitized regarding aging. So from the Ministry of Health, with the collaboration of the National Secretariat for Elders and community-based organizations, we do conduct youth sensitization programs where these youth personnel are sensitized on aging using this sensitization kit. And also, we also commemorate the International Elder Abuse Awareness Days, which is falling on 15th of June. We have developed advocacy briefs and IEC material, and awareness programs are conducted through mass media to upbring the knowledge on elder abuse. When we are addressing elder abuse, we do face a lot of challenges. The main challenge is inadequate data on the prevalence of elder abuse in Sri Lanka. And also, the older persons are not aware about the available legal provisions and available services. And also, even though we have the laws, the lack of law enforcement is a main challenge pertaining to elder abuse. So when we think about the way forward in addressing elder abuse, conducting more research and surveys on elder abuse, and establishing a sustainable information management system, and providing more awareness through mass media, and also empowering the older persons through elder societies, because we have a good network of elder societies in our villages. So empowering the older persons through these elder societies and also through the Elderly Rights Promotion Officer are identified as some strategies in the way forward to address elder abuse. So this is the end of my presentation, and I would like to give my sincere thanks for Dr. Mala Kapur Shankar Das for inviting me, and thank you very much for the organizing committee and all the participants. Thank you very much.
Thanks a lot, ma'am. Thank you, ma'am. Well in time, and very good concepts you have introduced in your session, and it's really a very important part that we learned from your session. Thank you, ma'am, once again. I'm privileged to invite our speaker, on the topic blaming victims of elder abuse and prevention challenges at community level, experiences from Nigeria, by Ozo Melvin, Professor, Sociology and Gerontology, Department of Sociology and Anthropology, Obafemi Awolowo University, Nigeria.
Thanks so much. Good
Thank you,
afternoon,
sir.
everybody
Welcome
from here,
once again.
and good evening to those of us in other parts of the world. Please, I need permission for me to be able to share my screen.
Kirtana, please make Professor Ojo as host.
Yes, sir. I have made him as the co-host and he can share his screen.
Professor Ojo, sir.
All right.
Yes, sir. Visible.
So I don't know
Make
if you can
full screen,
see
sir.
my screen now. Okay. All right. So thank you, everyone. It's a great pleasure to be with us in this webinar for today. I appreciate Dr. Mala and others for this
Sir,
great
your
opportunity.
screen not visible.
Is it visible right now? Hello?
No, sir, your screen is not
No, sir.
visible.
Okay.
Kindly share your screen, sir. Full screen you share, then little bit.
Yeah. How about now?
Yes, sir.
Yes, sir.
Oh, good. Thanks. So I sincerely want to appreciate the opportunity to share this research idea from Nigeria, and I've also been listening to the presentations from others talking about the whole issue of elder abuse. I'll be focusing my presentation, which is going to be very brief, on blaming victims of elder abuse and prevention challenges, drawing from an experience of a small-scale study in Nigeria. Like we all are aware, in terms of the various forms of elder abuse, it takes different forms. And part of those forms that are more prevalent within the Nigeria context are those related to physical and neglect of older persons as one of the common types that we have within the Nigerian context. To a large extent, in terms of the national prevalence, there are pockets of evidence from not really national large-scale studies, or then from estimated prevalences showing a lifetime prevalence of elder abuse at 18.6 and then 17.6 for some, while 1 year prevalence has been estimated to be 14.7 and 13.3, respectively, in both urban and rural areas. And so this gives us a sense of how prevalent this challenge is also within the Nigeria context, as well as how neglect is also a common problem among older people, both in rural as well as in urban settings. And so in terms of neglect, just like elder abuse, just like physical abuse, it also manifests in different ways, including denying older people access to care, as well as denying them the needed assistance, including access to medication and to healthcare services. So one of the common challenges that we have with respect to addressing the problem of elder abuse as a public health challenge in Nigeria is the challenge of underreporting, which will again also highlight in terms of how does the level of structural issues also stand as a barrier towards the reporting of elder abuse within the Nigerian context. Stigma also is one of the major contributors to this challenge of underreporting of elder abuse, as well as the assumption that older people are supposed to be given the respect that they deserve. But nonetheless, the value system is also changing, and this is also making it difficult for a number of people, older people, to enjoy the needed respect as they are culturally supposed to enjoy. We also have the problem of inadequate legal structures to protect the elderly within the Nigerian context, which is also, again, aggravating the challenge of reporting as well as addressing elder abuse in Nigeria. I'll be speaking to findings from a small qualitative study that was conducted a few years ago, which involved having a focus group discussion with older persons aged 60 and above, as well as key informal interview with community and religious leaders. The study itself was focused at looking at the explanations and the experiences of older persons with respect to elder abuse, in terms of what does it represent, what does it mean, and then why, in terms of explanations around the risk factors that are associated with elder abuse from their own point of view and from their own lived experiences. And so from this particular small study, the findings again resonate with part of what exists in the literature in terms of looking at the role of cultural beliefs, particularly with respect to witchcraft as a problem, which again is more or less like a stereotype around the view of looking at an older person who is poor, who is also not in the mainstream of the religious movement that we have within the Nigerian context. Nigeria is a highly religious country, like it's also common in quite a number of countries around us, and as well as even in India. So you have the Christianity, Islam, and then the traditional religious system as the predominant ones across the regions of the country. But for this particular study, the study took place in the southwestern part of Nigeria, where you have a mix of both the traditional, the Islamic religion, as well as the Christian religion as the dominant religion. So because of a high level of poverty, especially for older persons with low socioeconomic status, the chances of them being accused of being witchcraft or of possessing, being possessed by witchcraft is also common, which sometimes will lead to social isolation as well as neglect of these older persons by their relatives, as well as their neighbors. And so religion plays a critical role, especially with the high presence of Pentecostalism within the southwestern part of Nigeria, where the study itself was conducted, because we have the Pentecostal doctrine that speaks to the need for people to be spiritually delivered from some of the challenges that sometimes could also impoverish them. And so sometimes the tendency to also want to label some older persons within poor households as being responsible for some of the challenges that they have. It's also part of what again came up as part of the findings. Also, we also have a health system where you have both the biomedical system existing, although at a very high advantage over the traditional medical system within the context. And within this context, you have traditional healers who sometimes also are consulted, and sometimes some of them are much older, and some of them sometimes are also being perceived to be ritualists to an extent in terms of what happens within the cultural context. Also, part of the findings is the position of victim blaming, whereby because of the challenge of having this experience of suffering abuse as an elder person. To a large extent, at some point, this experience sometimes become more or less like a normal situation for some older persons, whereby they blame others, their peers, and those who are also going through such experience as being responsible for their abuse. And it was very interesting to also see how this has been internalized, even among some of the older adults themselves, where they see themselves as being responsible to an extent, which again we'll also see when it comes to some of the larger structural issues that also contribute to the chances of an individual experiencing abuse in old age. And because of this, it also impacts on how reporting is also done, including help seeking, and whether such an individual may also be able to assess support where such exists within the context. And so for some of the factors that I also mentioned, economic factor again also emerged as a bigger structural determinant based on the explanations that the study participants provided in terms of poverty and economic strain, how this has contributed significantly to the occurrence or the chances of an older person experiencing elder abuse within the Nigeria context. And in the last 10 decades, in the last 1 decade, the country has been moving towards liberalizing the economy, whereby the whole idea of allowing the forces of allowing market forces to determine access to production as well as access to services as in a very high way contributed to the vulnerability of both older and young people. But then it appears that older people are actually at a more risk than the younger ones, because to a large extent, some of them that's supposed to have access, for those of them that are retirees of the government, because of the challenges of managing pension for the last 20 years or so in Nigeria, quite a number of them would end up retiring from full employment without having adequate access to their pension. And where they do, whatever is being paid at the end of the day is too little for them to survive the economic challenges. And as a result of this, you have quite a number of older persons depending on their adult children who are also struggling to survive because of the unfriendly economic policies and the absence of a robust social security system for older adults in Nigeria. So because of this, again, you realize that because of this pressure and orders, even though this may not be the only determinant, but then again, a number of adult children and neighbors that are supposed to sometimes even provide the supports that they would willingly want to provide for older persons tend to also withdraw the support, and in the process, if an older person around in such situation is also not careful enough, then becomes perhaps somewhat vulnerable to abuse. And so within this context, I also try to look at, so what then are some of the challenges that we have? Okay.
Sir, almost time over. Please make it faster.
Okay, so some of the challenges in terms of prevention of elder abuse, we have cultural beliefs and practices standing as a critical factor in terms of the challenge. We have economic hardship, and then we have lack of social services as part of those challenges contributing to how to prevent elder abuse in Nigeria. And then most importantly also, there is this inadequate legal framework that has not been able to protect older persons from experiencing, from not being exposed to abuse and vulnerability in old age. And then there's also the problem of limited awareness around elder abuse, which again has also been impacting on what is considered as an abuse and how help can also be assessed where it is available. There's also the gender dynamics around it, because older women stand a chance, and those who are widow also stand a chance in becoming more vulnerable to abuse. There's the family power dynamics. This has to do with sharing of resources, especially when it has to do with inheritance and access to land and other properties. And oftentimes the older persons are those ones who are custodians, or somehow you then have younger people also trying to also survive by taking advantage of some of these resources that are available. And then the last point that is also a major challenge is the absence of data as well as national research around this issue, making it difficult for us to really understand the scope of the problem, as well as us to design preventive measures as well as strategies. And so I'm also thinking, based on the findings, that some of these strategies can actually be explored within the Nigeria context by creating more awareness and education campaigns, and then strengthening the legal protection systems, improving economic support for older adults, as well as harnessing community support system, and then looking at the possibility of introducing family mediation programs and training for caregivers for those of them that are just a few number of people have access to institutional homes that are also very scarce within the Nigeria context. So quite a number of people actually reside with their relatives and extended family members in their old age. And so when we look at what is happening within the Nigerian context, and also drawing from the findings from these small-scale studies, elder abuse and neglect in old age, it's a product of intersection of cultural, economic, as well as social factors. And so any intervention that will provide meaningful impact has to be multi-sectorial and has to be robust across structures.
I'm extremely sorry, sir. Please wind up your session, please.
Thank you. Thank you.
Extremely sorry. Thank you once again, sir. A very good and very relevant, valuable comments, and the status that you have defined in front of the participants regarding elder abuse in your country. Thank you, sir. Now I'm inviting the last and seventh speaker of technical session 2, Ms. Khushbu, research scholar, Baba Saheb Bhimrao Ambedkar University, Lucknow, and she is going to deliver her talk on wellness in aging population. Khushbu, are you with us?
Yes, I am. Am I audible?
Yeah.
Hello?
If you have slides, please share.
Is it visible?
We are running late, so Khushbu, you have 5 minutes of time.
Sure, ma'am.
Not yet.
Just check, ma'am. It is showing that it's sharing already.
Yeah, it is showing.
Yeah,
Please make it full screen.
It is now visible on full screen.
Sure. Good evening, all RC12 members and researchers from across the globe who are presenting their views on aging populations in their own respective countries. I'll be presenting my presentation on wellness in aging population. Wellness in aging population involves addressing multiple aspects and of health and well-being, and to promote high quality of life of people who age. This also includes physical, mental or emotional, social, financial or occupational, and various other aspects. Each of these dimensions is interconnected, and balancing them is key overall wellness. A deficit in one of the area can affect others, and thus it is essential to nurture each type of wellness to achieve a well-rounded, healthy life. If we define physical wellness, it focuses on maintaining a healthy body through exercise, nutrition, sleep, and also preventive care. It also encompasses avoiding the harmful habits and managing the chronic conditions and vitality. Mental wellness or emotional wellness. Mental or emotional wellness in aging is crucial for maintaining a high quality of life and significantly impact both physical health and longevity. As people age, they face unique challenges such as retirement, loss of loved ones, declining physical abilities, potential isolations, and all of which can affect mental health. Mental and emotional health in aging includes a number of such aspects, in which the first one is cognitive stimulation, in which reading, puzzles, learning new skills, or playing musical instruments can help preserve the cognitive functions and delay or reduce the risk of cognitive decline, including dementia. Social engagements with family, friends, and the community help maintain the mental agility and also the emotional well-being. Lifelong learning is like continuing the education and also the intellectual curiosity that can improve cognitive reserve and help the brain stay resilient at all the stages of life. Managing stress and anxiety. In this, it could be of financial concerns or the loss of independence, or this can be reduced by stress reduction techniques such as mindfulness, meditation, or relaxation exercises, and can promote emotional balance. There's grief and loss at this age. Loss is common and it's part of aging, and whether it's the loss of loved ones, physical abilities, or life roles. Seeking grief counseling, joining support groups, or talking to a mental health professional can help process these feelings. Most important thing is, specifically after the COVID phenomena took place, depression is common among all the older adults, but it's not normal part of aging. There has to be a recognition of symptoms like persistent sadness, lack of interest in activities, or changes in the sleep patterns. And you need to seek treatment for these in the form of therapy, medication, and also lifestyle changes. Now, social wellness or the environmental wellness. I have joined the environmental wellness and social wellness because social environmental is an important aspect and other aspects. Avoiding isolation, volunteering and community engagement, self-esteem and purpose, spirituality and mindfulness, access to technology and telemedicine, chronic illness management, and there has to be a holistic care of all the mental and physical aspects. In India, the senior citizen, that is people ages 60 years and above, currently comprise a little over 10% of the population. And translating it to 104 million. The United Nations Population Fund, that is UNFPA, projects that this population, which will make up to 150 million people by 2025, is the one that is aging at the fastest rate. By 2050, the elderly population is projected to rise to 319 million, which is 19.5% of the total population. This has been taken from a working paper on social reforms. And this is also from United Nations World Population Prospects, the 2019 revision. The population by broad age group in percentage in India in 1950 to 2050. Here, you may see that the total dependency ratio, which stood at 56.92 in 2020, is projected to decrease steadily till 2025 due to the rise in the percentage of the working age population. But it is expected to rise again to touch 61.22 by 2050. I have also shared the key findings of the LASI. It is also part of the social reforms working paper. The LASI launched in 2016, as we all know, by the Ministry of Health and Family Welfare, is a full-scale national survey and seminal study on the status of aging population in India. The report has provided several valuable insights into the process and impact of aging in India. The key highlights of the report are given below. And every fourth Indian over 60 years and every fifth Indian over 45 years have a poor health. 75% of the elderly have chronic diseases, and 40% of the elderly have one or more disabilities. There are more than, excuse me.
Ma'am, make it fast, ma'am.
Sure. 1 in 4 has some kind of multimorbidities. Diabetes is the most common among the senior citizens in urban India. Cancer prevalence is on the rise and is higher in urban India. As far as the mental health is concerned, around 20% of the elderly in India have mental health issues, and the prevalence of the probable depression among the elderly is 10 times higher than the self-reported prevalence of diagnosed depression, implying a greater burden of undiagnosed depression. These are all basically what since we are focusing on the Indian scenario. At least 5% of India's elderly population reported has experienced abuse, which can be physical, sexual, psychological, or financial. Mistreatment is more common among the elderly women and those living in the rural areas. Digital wellness is also very key and important aspects in aging population with respect to India. Male senior citizen works at approximately 50%, while the female senior citizens work at a rate of 22% only. When compared to their urban counterparts, a great proportion of the senior citizen in India's villages do not get pensions. 78% of the elderly population are without the pension access or the healthcare finance. Only 18% of the seniors are covered by health insurance. Health-related expenses is most common and cause of indefinite. Yes, ma'am.
We have shortage of time, please.
Okay. This paper is based on the articles in journal government reports, self-published articles on the wellness. Basic aim is to find key areas of research in wellness in aging population in particular. Second objective is to, with respect, special reference to India, identify methods and means to promote wellness in aging population. Conclusion is fostering wellness in aging requires a holistic approach, addressing both preventive measures and interventions tailored to individual needs. The aging of the population presents unique challenges for various nations and societies. The response to the challenges of the population aging should take into account the realities of each country or the region, avoiding one size fits all. This approach has also been encouraged by the LASI. Societal structure needs to be considered when it comes to the study Indian aging population, considering all the genders, including the third gender, religion, regions, and other social parameters. Thank you.
Okay, thank you, Khushbu. Thank you. Well done. So, Dr. Bala Murugan, sir, our co-chairperson and professor of Sociology, Department of Social Sciences and Language. Do you wish to sum up the session, sir? Dr. Bala Murugan, sir, do you wish to sum up the session?
Yes, ma'am. If you want, you can launch.
Excuse me,
Yeah,
may
ma'am.
I just request, please don't give any summaries.
Okay,
Just let the discussion in case there is anything in the chat box. And if, as the chair, you have comments for any paper, please put it in the chat box. We are really running late. And, we would have to apologetically drop these very important aspects of our webinar. Because there will be for the later sessions, people joining from US and all, and it is not going to gel with their time if we are going to be late. So the valedictory and the third session has to go on in time. Thank you so much. Please
Thank you.
put your comments in the chat box.
I
But let
Dr. Bala Murugan,
co-chair
sir.
make his last closing comment.
Yeah,
But don't
last closing
summarize
remark.
the
Fine.
things. Thank you.
Sure, ma'am, sure. We skipped. The request Bala Murugan, sir, our director of RC12 and associate professor of sociology from VIT, Vellore. Please sum up the session with final remarks.
Thank you, ma'am. Respected organizing secretary, respected convener, respected co-convener and secretary of RC12. So we have 7 presentation, all 7 presentations presented by the expert as well as research scholars. So every sessions are different aspects, like from various country like Singapore, Nigeria, Sri Lanka, like this. So with this brief summary, like now we would like to conclude this session. Now this next session will start. So now I like to request our admin will take care and continue the next session. Thank you.
Thank you, sir. Thank you.
should we begin the third session? Dr. Shankar Das?
Yes, please begin. And Dr. Ruby, may I request, time limit for each speaker to be reduced a bit, and even comments all to go in the chat box. That will be appreciated. Thank you so much.
Good evening, everyone. At the onset, I would like to congratulate the organizing committee and the speakers for having selected this very, very pertinent theme for the session, intersectional perspectives. This theme actually very cogently draws our attention to the diversity and the differentiated nature of our elderly population, and at the same time also points towards the diverse nature of the vulnerabilities that they may be suffering from. So, for example, the vulnerabilities of women may be different from those of the dependent population and those of people who may be suffering from psychological, mental, or even physical debilities, and they may be impaired and requiring special attention. So, these are the kind of issues that we are going to look at during this session, and we look forward to the discussions that will not only sensitize us on this very, very sensitive issue, but also help us envision a society which will be humane and prepared for the kind of care and dignity that our elderly deserve, and so that we can actually celebrate our upcoming silver dividend. With this hopeful comment, I invite our first speaker of the session to please begin their presentation. But before that, I would also like to point out that kindly limit your presentation to 10 minutes. I apologize in case I need to interrupt your presentation if it goes beyond 10 minutes. Please keep your mics in a mute mode, and also remember just to type in your questions in the chat box. If time permits, we will take them up.
Excuse me, Ruby, please, can you also request the paper presenters from 5 minutes to make it 3 minutes, which is after the main presenters.
So experts who were allocated 12 minutes may please limit your paper to 10, and those speakers, we have a few speakers at the end, please limit your paper to 3 minutes only. It's a very sincere request because we have to adhere to the timelines. I request the first speaker to kindly begin her talk. This is Dr. Elham Lotfani Zahed. And please, I invite you to start. I'm sorry. Our first speaker here is Anna João Santos, who's a researcher. Please, can we have you, Anna?
Yeah, sure. Can I share my screen?
Yes, please.
Okay, so I'm going to try to share the screen. Is everybody watching the screen?
Yes, it's visible.
Okay, so first of all, I'm going to try to stick to the 10 minutes. Thank you very much for the invitations for this very comprehensive webinar on the thematic. My name is Ana João Santos. I come from Portugal, and I'm tackling a little bit of the multidimensionality of elder abuse and trying to integrate it in the role of public health. Oh, sorry, this is not... I'm going to try to be really quick. Just a minute. Something is... Okay, something... It's not happening. Okay, so screen one share. Okay. Okay, so very quickly, I'm going to talk about multidimensionality and present some data, secondary data analysis to two projects that I was a part of in Portugal that were trying to tackle multidimensionality and try to see the difference between different elder abuse configurations, and then in the end, a little bit on public health. So what is multidimensionality? So first of all, the idea that elder abuse is a uniform
phenomenon has been contradicted by research results. And because, for instance, you can have somebody that is bedridden, dependent in a nursing home that is neglected by a professional caregiver, and this is elder abuse. But you also have, for instance, interpartner violence in older ages, and this is also elder abuse. So the idea of multidimensionality is the idea that elder abuse, it's not a uniform phenomenon. It's a very big umbrella, and that it's possible that different configurations may have different explanations, determinants, and consequences. So in order to look and address and understand elder abuse, maybe we should not try to see it as a uniform phenomenon, but see it in the light of these three things: the relationship between victim and perpetrator and the abusive behaviors. So here I'm going to present secondary data analysis for two different projects. One was a prevalence survey tackling older adults residing in the community. So this was a national representative sample through telephone interview of a validated structured questionnaire. And the other one was a victim survey. This is a convenience sample of older adults that sought victim support organizations, social services, even the police, to ask for help for their abuse situation. And in this case, this was done through face-to-face interviews of trained interviewers. So how to address multidimensionality? Is it possible to see this in data? So what we did was we tried to see if there were natural configurations of victimization experience by using the method latent class analysis, to see if there was natural groups according either to type of physical abuse or to perpetrator. So we did this in both projects, the prevalence survey, only the victims of the prevalence survey, and in the victims survey. We included seven items, distinct items of abusive behaviors, from psychological abuse, physical abuse, and financial abuse. And we included three categories of perpetrators: children and grandchildren, partner and spouse, and other. So regarding the prevalence survey, we did found 6 classes of or groups of victimization experience, even though some are more distinct in terms of statistic results are more distinct than others. The more frequent one was verbal abuse by others, followed by psychological abuse that included more than one type of abuse behavior by children and grandchildren, and then overlooked by others, stolen by others, which were the more distinct groups, and then verbal interpartner violence, and in the end, the least frequent one was psychological and physical interpartner violence. In the victim survey, we also found 6 groups, 6 classes. The best model is according to statistical indices. I'm not going to discuss this, but we were also surprised to find the same amount of groups. But in this case, because the sample was very different, because these were people that proactively went to seek help, so we knew that the sample was much younger, and most of the abuse they were reporting was related to nuclear family. So in this case, the most frequent group was physical abuse by children and grandchildren, physical interpartner violence, physical and psychological by children, polyvictimization by others. And in this case, we're including several types of abuse: financial, psychological, and physical, then physical abuse by others, and in the end, physical and psychological interpartner violence. So even though none of us believe that these groups actually portray rigorously the reality of the different victimization experience, they do let us know that it is possible. There are several distinct experiences according either to abusive behaviors and perpetrator. What was interesting was that the others, the groups that were included where the perpetrators were others, people outside the nuclear family, were the ones that were statistically more different from the other ones. So children and grandchildren and the groups that were within the interpartner violence were much more similar. Financial abuse behaviors were only important to distinct groups that were included perpetrators outside the nuclear family. We think that this may be due to the fact that a lot of victims do not see financial abuse as financial abuse within certain relationships. And this was later also observed in a qualitative study that I'm going to shortly present. But more important than the elder abuse configuration, what we tried to do was to try to check if those configurations led to specific victims profiles with different characteristics. We did find that the older age group, a higher proportion of older age individuals in the groups perpetrated by individuals outside the nuclear family, and youngest age group, 60 to 69 years, in the groups where interpartner violence was reported. Also, this is there's missing, but older women living alone were within much more frequent in the groups physically and psychologically abused by children and grandchildren. And while we did had a higher proportion of women reporting abuse, a higher proportion of males with dependency for their activities, daily living, were actually included in the groups where they reported abusive behaviors by individuals outside the nuclear family. So, okay. Afterwards, we did a qualitative study that I'm going to shortly try to present. We did a qualitative study to try to understand, okay, we know there are different victimization experience and there seems to be different characteristics or risk factors of victims according to these different configurations, but is there a similar narrative? So we try to explore the narrative of time, old aging, and this process within the abuse happening. So we did find that there are two different categories that one was aging violence. This is the process where people were already victims of abuse and then this progressed to older age, and then violence after aging. And these two groups, while share similarities, for instance, the history of violence, the importance of relationship. So in their narratives, they tell there's a relationship that getting tenser and more conflictual until the abuse happens. But the abusive behaviors were much more physical abuse and psychological abuse in aging violence. And there were differences also in interpartner violence. So in aging violence, these were always linked to first marriages, one-time relationships, while in violence after aging, the only cases of interpartner violence were second marriage or second romantic relationships. Interestingly, also, the aging is seen by all the victims, independent of the relationship or the context, as a process of vulnerability. For all of them, this is a vulnerability to the consequence, to the effect of violence, and only for the victims whose perpetrator was reported to be children and grandchildren was this vulnerability linked to violence itself. So these victims saw themselves within the aging process as this was a risk factor for me. This increased the odds of me being abused. So how to design a shoe that fits all sizes? I think that according to these results, other studies, and a lot of literature, we cannot deny that there are different configurations of elder abuse according to the context, abusive behavior, relationship with the perpetrator. However, there are also cross-sectional features. So some of the victims' risk and protective factors, the consequences, and also the aging. And I think the relevance here is how aging impacts all of these different configurations. So going back to public health and to the multidimensionality. So if we look into the public health field, there's a lot of different domains or issues that it can be brought in regards to elder abuse. I think that looking into the multidimensionality, two of them are really important. One of them is the comprehensive framework. So public health already has a multidisciplinary approach. So it's not new to integrate something as with the complexity of elder abuse that encompasses several different types of behaviors, relationship, cultural, familiar, and different contexts. So comprehensive framework to actually understand elder abuse and also to address elder abuse, integrating different insights from different disciplines and examining these multiple dimensions simultaneously would be can be easily integrated within the work and the approach that public health already has. On the other hand, also the development and implementation of strategies. You have aging that we have a lot of public health approaches to promoting healthy and active aging, and you also have elder abuse.
May I
In
request
terms
you
of
to wind up in 2 minutes, please?
Yep. So focusing, obviously, the approaches to aging are always beneficial to elder abuse on the prevention strategy. But into elder abuse, the fact that public health can propose population level solutions, this interdisciplinary framework, and tailored interventions encompassing multiple dimensions. I would say that we do not have the means to have a case-by-case intervention program or strategy, but we can have a conceptual intervention strategy that encompasses these multiple dimensions. And also, I would say that public health is really important at the policy and systems level change, because I think in regard to other fields, it has a much more potential impact and relevant impact. So thank you very much. I hope I didn't get on too much.
Thank you for being so cooperative. May I now request Mr. Isaac Oekola to please begin the presentation? Mr. Isaac Oekola?
Ma'am, I think he's not there. I searched for his name. It's not there.
All right. So can we request Dr. Navneet Kaur?
Yes, ma'am, I'm here.
Thank you.
May I start, ma'am?
Please do.
Yes, thank you. Good evening, everyone. Respected chairperson of the session, Professor Ruby Bhardwaj. The topic of my presentation today is digital exclusion vis-a-vis digital distress, a neglected issue. Digital devices are here, digital devices are there, and digital devices are everywhere. But old people are far fearful, and it is absolutely not fair. You will agree with me that the major development of our times is the coming of digital and smart technologies. Secondly, the life expectancy is rising, which means old people are living longer. Does living longer means living smarter too? The combination of the two is supposed to be positive, and it is assumed that smart technology can help in making the aging population smarter. But this is not true. Digital exclusion and digital distress among older adults is an important public health issue, but a neglected one. Digital technology constantly demands our high-quality attention and brain power. The so-called user-friendly apps that work at the touch of the screen are actually adding emotional fatigue and distress in case of elders. Let me tell you that the digital society which we use has two components. One is the social media platform, which is used by many for entertainment purposes, like watching the e-content, passing time, and socializing on Facebook, WhatsApp, Instagram, YouTube, etc. Second important component of digital society is providing essential services like banking, healthcare, and other public services. On the services side, there is consistent widening of the digital divide and exclusion of the older population from the technological society. This is called the age-based digital divide and gray digital divide. Let us understand from a few observations about the digital access, usage, and barrier of using technology by old age population. Older people are functionally dependent on caregivers and family members. One 87-year-old man has 5 phones. Every time he fights with his son that he doesn't buy a good phone for him where he can hear the call properly. The son explained that his father needs hearing aid and not a new phone, but the father is not willing to go to doctor for this. Instead, blames him that he doesn't buy a good quality phone for him. Another instance of 85-year-old man who fights with his children that why they have bought complicated smartphone and smart TV. Son says that he's not willing to learn the operation of new smart TV every time there is an issue at home over this. If we don't buy, our relatives feel that we are not looking after the digital needs of parents. Another instance of 76-year-old woman who keeps on requesting her grandchildren to teach her how to use Facebook, how to send pictures on WhatsApp. She says she cannot memorize the steps. She writes and then she forgets. Children have no time to repeat the digital lessons. She feels dependency has increased, which bothers her. Many a time, she doesn't approach children for such issues as she feels children are busy. The old conventional TV is a smart and slim TV that the old conventional TV is now a smart and slim TV that works with DTH service providers like Tata Sky or Dish TV with HD channels that need online recharging. Now, old people have to request and remind their children for recharging and they feel dependent. Another woman of 75-year-old says she has a smartphone. Children have made her account on Facebook. She happily uses, but she cannot book a cab on Uber or Ola. She cannot buy grocery online. She cannot order anything online as she is scared of using technology. She finds herself dependent on children for everything, as everything is getting online. She loves going out to buy things from the store, but children prefer online shopping. Even buying a phone is very difficult for her, and loading the content on phone, she will not prefer. In yet another case of an old woman of 77-year-old, she mentioned that her smartphone is the only reason her grandchildren come to her. They want to use the phone, they sit with her, they play game on her mobile, and after playing online games, they go back. This smart technology is the only reason young tiny tots and children are visiting their grandparents. It is not the grandparents' stories and their affection that pull the young children, but it is the gadget that is pulling the grandchildren towards the grandparents. In yet another instance, old couple remarked that the drawing room conversations revolve around technology and they feel alienated. No one has patience to teach them, and the willingness to learn is also fading. Talking to a few older people for this presentation, it was observed that old people find the technology too alien and they have become prehistoric in today's era. There is no willingness to learn. They don't know how to order online if any medicine is finished. They feel they are finished. Their heart sinks with the thought that their medicines are out of stock. Sometimes they feel they don't know what to do in an emergent medical situation. Having smartphone does not equip them or prepare them to take any emergent action in an emergency. Thus, it is not only lack of access, but it is also the limited ability to access essential services. It is also the lack of digital skill that affect their ability to adapt to the digital age and access the online resources. Further, complicated interfaces and fast-paced technological changes pose challenges for seniors. The entire interface is so quick in action, inbuilt sensors, and the touch is so quick that they don't even realize what is happening. How can we think of telehealth services, booking an appointment, cancellation of an appointment would be used by them? This acts as a barrier to accessing remote medical assistance and healthcare information. By looking at these instances and many others of urban households, it seems that technology has not facilitated the old age, rather made them a way more dependent. Review of literature and some observations from the field mentions that older adults lack digital literacy. They lack information literacy and knowledge literacy. The usage gap and the memory issues have added fuel to the fire. What kind of well-being are we talking about? Is it a well-being of physical health? Is it a well-being of mental health? Or this is a memory issue? Using digital platform means life of passwords. Internet's life is a life of passwords and OTPs. The elders' memory issue do not allow them to memorize multiple passwords. For every platform, for every account, they need a password with a special character, and it is not an easy task with anyone.
May I request you to wind up in a minute or two?
Yes, ma'am, I'm doing it. Do we still think that AI and Chat GPT in the current scenario are going to help the elderly and revolutionize the way we live and work? The slow-moving generation and the pace of technology and digital platforms is a serious mismatch. Digital world is full of thrill and ambiguity. The elderly cannot digest the thrill of cyber frauds. Digital world is like an ocean with new experiences, expressions, information, boundless knowledge, unimaginable opportunities, and a picture-perfect life. Elderly population have lived life without this sophisticated technology, and now suddenly they are finding everything online. Carrying this portable device 24/7 and enormous information, including false information, is not an easy task. Those who are not on digital platforms, they feel excluded. And those who are on digital platforms, they feel some days they are easy, they are happy to use WhatsApp, and next day they are finding it difficult to locate that same icon on their phone. The distress is due to the information overload. It is due to the cyber fraud. It is a global phenomenon in both the developed and the developing countries. So it is not the equipment barrier, usage barrier, skill barrier, but it is the mental barrier. It is the memory barrier that hinders the use of the digital platforms in all the countries. Additionally, age-related changes such as decline in vision, hearing, cognitive ability, these are the contributors to the great digital divide, which is emerging as a major challenge. When the current generation, I really wonder, when we people are going to become older, we will be skilled to use digital platforms, but people like us who are daily technologically upgrading ourselves, isn't it going to be difficult for us? Because it is the moot question that this is going to be with the health challenges which come automatically with the old age, the vision and the hearing issues, the confidence to manage the technology, the memory issue, to learn the passwords. Thus, the health challenges and emotional fatigue is going to continue to contribute to this digital distress. Already, the experts are looking for strategies to detoxify the youngsters. They are suggesting ways that you remove the technology for a few hours. Some people are even planning their digital-free holidays. Now, at this juncture, we need a multidisciplinary approach to investigate on this topic with the help of primary data so that we fulfill the promise of sustainable development goals, that no one is left behind, and at the same time, the well-being of everyone is taken care of. Thank you very much.
Thank you, Professor Arora, for presenting so succinctly what we all find such a familiar situation in everyday life. Thank you so much. I now invite Professor Chandana Sarma to please make a presentation.
Very good evening to everyone, respected chairperson and the organizers of this seminar. I hope I'm audible.
Yes, you are.
Okay. So I would like to thank the organizers for this opportunity. And this has been an enlightening experience for learning about so many diverse aspects of, I think I am not allowed to share. Maybe I had shared the PPT with the organizers. Maybe the presentation would be from there, or will I be allowed to share the presentation? Because I am not allowed to share right now. I have to be given.
Admin will have to make you the co-host.
That's right.
Yeah. Can we have Professor Chandana Sharma become the co-host, please? The admin, please look into it.
Or it can be shared from the end of organizers' end also.
Yeah, I mean, somebody.
Professor, actually, there was some technical error. ISS has become the host again now. I will, before that, I will share this, myself will share the slide.
Okay.
One minute, give me a minute.
Sure.
Okay. So this has really been an enlightening experience in the sense that, as Professor Ruby Bharadwaj has mentioned in the beginning, that about the diversity and the intersectionality in the elder abuse dimensions. And today I'm going to talk about an aspect which is like, when I was initially thinking about talking about this aspect, whether it would really come under elder abuse or not, but I was wondering. But now looking into this aspects of, so many, if we have a continuous mechanism of neglect, I think that can take the form of an abuse for elderly persons. I want to talk about, or I had taken into today's topic that I want to talk about is the age-friendly cities, like how age-friendly are our cities. Since I come from the anthropology background, I have taken the case study of Guwahati, which is my hometown, and I had been staying here since my birth. And my PhD was also on this in Guwahati, and I have seen a wide range of change that has taken place in the social context of Guwahati and how it had affected the life of elderly people. Is there some issue?
Now it's visible, ma'am.
No, it's not. It's not visible. Okay, so we have seen about some of these aspects, like the characteristics of India's elderly is that most elderly live in rural areas. The feminization of aging, as we have all talked about, including the feminization of abuse, and also the growth of the larger, older sections. But what we see is that, even though majority of our elderly population live in rural areas, a large section of the society elderly also live in urban areas. In the northeastern part of India, we have around 19% of the population, 19% of elder population, which live in urban areas. Urban areas, they also, can I have the presentation or?
Yeah, actually, I'm trying, ma'am, but I have opened the presentation because
Okay.
it's.
Or you can make me the co-host.
Yeah, sir, can you make her the co-host, please?
One minute, ma'am, because I have to call Boino from ISS, then only I can become the host again. It will take some time, so I don't want to waste the time.
Okay, so I will continue.
Yeah, please continue, ma'am. I will try to share.
So we have this.
Visible now. It's visible now.
Is it visible?
Yes, yes.
Okay, okay. So how do I proceed? Like, what do I have?
This
I
is
think
actually the
changing
title
the
slide.
slide.
Can we just change the slide, please, to the next one?
Now it's visible, ma'am.
It's the title slide which is visible. The
Now?
first, yes. Changing demography is visible now.
Yeah.
Okay, so we have, I don't think I'll go too much into this because a lot has been already discussed about these issues, the changing demographies and how this, the dimensions of are changing. And when we talk about well-being, or when I say, what are the aspects that we generally think about? So well-being can be ensured through a mechanism of what we call as social inclusion, and this could be through social support and the kind of interactions you have with the people around you, and also creating possibilities for active aging. So active aging, where we remain both physically, functionally, and mentally active to take decisions on our own. And another aspect which I feel very important for us is that aging in place. That means we age in the community or the place where we are living in, and that would help us, age and remain in an active manner. So remaining both physically active and socially connected ensures both mental and physical health for elder individuals, and this can be achieved through creating an age-friendly environment, which is very, very important for ensuring all of the above. We can proceed to the next slide. So we have all the different kind of, world organizations like the United Nations or which declares 2021 to 2030 as the decade for healthy aging, and the WHO the age-friendly cities framework, which all talks about creating a age-friendly environment, because social participation, external environment, and civic participation are important constituents of the frameworks that had been put forward by both the United Nations as well as the World Health Organization. And the physical and social environment, as has been pointed out in both of these the policies of these two organizations, that they can majorly influence how elder persons experience the aging process. So I want to look into, please, you can change the slide, that we talk about Guwahati, which is a city in northeastern, which is the capital city of Guwahati, Assam, and it is in the urban, urban area, which is in the process of converting into what is now been is called as a smart city. And in the process, so it is undergoing rapid urbanization as well as modernization. And because it serves as the gateway for the northeastern part of India, it is having large number of migrants, that people moving from all over all the other northeastern states migrating to Guwahati and setting up residences here, they're living here. So this changes, it has greatly impacted the urban scenario of Guwahati, and this in a large way have impacted the lives of elderly people. So what used to be friendly, supportive neighborhoods have now been converted into localities which are full of unfamiliar people, and there are very few people who seem familiar. So this familiarity is also something that elderly people, they take, they can find they find, they want familiar people or familiar places around them so that they find comfort. So now the developments that are taking place are mostly youth-centric, and where the infrastructural developments, they tend to limit the functionality that we see in elderly people. So they are limiting the functional aspect of that means the ability to move about independently. There are traffic congestions, road conditions, which have to a large extent hindered the social participation of the elderly. So in this context, what are the it has been discussed in various literature, and to understand what constitutes an age-friendly urban environment. And here, some of the major aspects that have been identified are the accessible infrastructure. That means the infrastructure has to be accessible, usable, and the elderly, as well as all other age group people with limited mobility or disability, may be able to use them without any hindrance. Then the outdoor spaces, that it should have the constituents like that of the urban infrastructure. Then the healthcare and social service facilities, the home environment should be usable for or suitable for elderly people. Then the concern about safety and security. And the most important aspect among all of these, which I feel, is the social inclusion. That is the scope for social participation, recreational activities, as well as the intergenerational social activities, which seem very important, which are important for creating an age-friendly environment. But what we are seeing in Guwahati is that a large number of developmental projects are underway because of the process of converting the city into what is termed as a smart city. And in the process, the whole infrastructural changes that are undergoing has kind of limited the functional aspect of functional mobility of the elder populations. So there are traffic diversions, so that they do not find the ability to walk about on their own. So there is increase in vehicular traffic, and proper footpaths are not maintained, where even if the elderly, they have functional independence, feel limited to move about on their own because of the kind of developmental or construction works that are going on. So maybe 5-6 years from now, the city would develop into a good infrastructure, but the people who are living at it in the current context are really undergoing a lot of health issues as well as functional health aspects. So this considering the the landmarks, like how the change has taken place, how familiar landmarks have been changed. Like most of the houses which were earlier independent homes have now been converted into apartment blocks, which have a large number of people living in them. The densities have increased. And there is, as I had mentioned earlier, a large number of migrations taking place from other states, as a result of which there is a lot of cultural variation. So the neighborhoods, they not only see people from their own cultural background, but also for people who are from a very different cultural background situation. So these things tend to have an effect on the the social participation and of the elderly. So they become, because of this, they have to become more dependent on other family members, or also maybe on outside help, which may not be so regular, or which may not be reliable in the true sense. So there are limitations to public transport facilities. There are special transport systems had been started for elderly, but because of various factors, this have not continued. So the public transport is not something that the elderly can use very conveniently. And as Professor Arora had also previously talked about, that though there are facilities of cabs and other things available, there is limitation about how much these facilities the elderly people can avail. So, and what is more, why we find that in the public places that there is no easy access and usability among elderly, it is primarily because of the absence of any guidelines in the building constructions, which makes it mandatory for the buildings to have proper accessibility to elderly people. There are countries like Netherlands which are specific and very strong building instructions that they have to make these public places accessible to elderly and with people with different levels of disability or mobility. But we do not find these aspects taking place or occurring in Guwahati. And in public spaces, very simple things like, the flooring, the kind of, colors that are used for flooring, where they are not made, in a way where the elderly can move more freely. Like even very newly constructed buildings like the DC office, which had been constructed very recently, it had not taken into consideration these aspects of monochrome floorings and staircases, which sees a large number of footfalls for all age group people, but yet this, because of these monochrome colors that are used, the elderly find it very difficult to use these floors as well as the stairs. So these aspects have to come into this, directives. The guidelines have to be given to the building constructions while they are being constructed, that all these things need to be taken into account for making them accessible to elderly people. Then aspects of handrails and toilets, which are suitable for elderly people and the people who are moving about in maybe wheelchairs, the need for ramps, etc., are not really incorporated into the public spaces. And regarding the outdoor spaces, even when Guwahati has undergone rapid modernization as well as urbanization, not much planning has come into this into the process. Planning has been taken into consideration, where Guwahati lacks a lot, very the green spaces and blue spaces where the people of all age groups can go and spend some time for both their mental as well as physical health, for improvement in their mental and physical health. So this unplanned.
Can I request you to wrap up soon?
Okay. Just maybe one or two. So this green spaces are not available, and even wherever the parks are available, there are mostly areas where they are not easily accessible to elderly people. They are not in close to residential areas. And in case of health services also, we do not find a regular and what we call as formalized health service sector, hospitals, geriatric care. All these things are lacking, and there are not much available trained nursing or geriatric nursing facilities, nor are NGOs and other support services available. And the safety security aspect is also one thing where there's been many instances of theft and mugging and all these things. And the police in Guwahati had developed a system of where, people who are living alone, elderly people who are living alone, they can register with the police local police station for emergency service help. But considering the kind of the image our police system has, most elderly feel they are hesitant to register with the system because of other repercussions that they might be feeling. Though we have some mechanisms like the Namghar in Guwahati, where this is in Assamese society, where older people can congregate and they tend to mix together. For these are places of spirituality, but where they provide avenues for social interaction and other aspects. But what we see that because of the kind of infrastructural and the aspects, that means which are not helpful for elderly, such places have not really been helpful for elderly as mechanisms for social participation. There are a few legislative aspects also, some social what we call as the senior citizens work groups have come up, but they tend to be mostly among people who have retired from service or who are not who had been working. But the people who had not been in the organized sector, they tend to be isolated from, or they are not able to participate. So these things have to be taken care of in order to develop an age-friendly environment. So when the concept of Vision Vikshit Bharat, if we leave behind the growing section of elderly behind, in trying to have a developed nation, we have to take into consideration this section of the society.
Thank you so much for your insightful presentation. I would now like to request Dr. Monica Rao to please commence your presentation. Please, could someone please share her PPT?
Thank you. Thanks a lot, ma'am. It's my proud privilege to be part of this academic forum where all the stakeholders, those who are working against elder abuse, are together fighting for this, to have a society which is free from elder abuse. Can I start my presentation? Yes, or somebody's sharing?
Admin, please, could you share Professor's...
So meanwhile, let me thank to the organizers for inviting me as an expert lecturer for the expert lecture. I congratulate ISS, RC12, INPAEA, DWRE in general, and Professor Mala Kapoor, Professor Prabhakar, Professor Ziauddin, and Professor Ruby in particular for having me in this session. So can I have my presentation, or shall I start if time is not permitting?
Mr. Prabhakar, please, could we have the presentation?
Issue, not an issue, ma'am. Just let me put this way, that because my title of the talk is Healthy Aging Free from Abuse, a call to action for prevention and support. So when we are working for prevention and support, so anytime we have to be ready, that should be the mindset. That is what the students in particular, my message from here is. So in my mind, seeing elder abuse and doing nothing is like sharing the role of the abuser. So if just like when we say that if you see a fraud and don't say anything, you are actually the fraud. As
Naseem co-host, if you want, you could start sharing your presentation. You have been made the co-host.
Okay, ma'am. Let me just... My slides are visible, ma'am?
Yes, yes, they are.
Okay, thank you. Since time is not permitting us to go into the details, my focus would be on 4 major aspects in this coming 10 minutes. One is how this healthy aging free from abuse. So what could be the modalities, how we can develop a model for working against the elder abuse. So first and foremost, I think healthy aging concerns measures and how we can measure all the aspects like lifestyle, positive aging measures, monitoring of state action, interdisciplinary research, approaches in education and innovation, especially intertwining the physics, geriatrics, and gerontology. Second would be abuse-free society, when age-friendly society for all ages. the framework, what can be the framework for it? So based on my research, I have proposed a framework. So I'm going to share in a minute or two. A call to action for prevention. So what kind of actions we can take at this moment? Our researchers, especially the budding scholars, how they can promote their research in the field, since being part of the university. I think we have to develop mindset in our students to work more and more comprehensively in reference to intertwining with other disciplines. Fourth aspect, which I think is appropriate to discuss over here, is support for age-friendly society. So how age-friendly society model, the idea, the entire approach can be supported by all of us. So that these are the four things which I think should be considered when we talk about healthy aging free from abuse. Since part of Department of Sociology, and we have a specialization paper of Sociology of Aging, and from next year onwards, we are going to launch a certificate course also on positive aging. It's a healthy aging and positive aging. It's a certificate course over there. We are going to launch. This is first of its kind in Rajasthan. So where we are trying to have an amalgamation of all the possible ways in which we can support the elder abuse, means we can actually protect the society and work against the elder abuse. How scientists, zoologists, physicists, technocrats, geriatrics, law professional, counselor, all of them can come together and have this thing. So this is just for the information. Now, as I said, there are four aspects which I consider can work as a model. First is health concern. My personal minor project under DRS3 in our department SAP, I have worked for framing a age-friendly society, the proposal and the policy decision. Now, as a broad overview, right-based category. So the whole focus of my project was how we can have a society which is actually duty-based society. We can divide the society into two, static and dynamic approach, where we can talk about the right-based and duty-based categories. So now here we can more focus on the right-based category of the as a senior citizens. And now when we talk about right-based category, it's not only the duties should be shifted to the younger part of the society, or the children's or grandchildren's. My concern over here is we have to have all our efforts to make no stone unturned to make sure that how we can have that society where all of them, all this section of the society are aware about the rights of the elderly. Second, how we can make them the implementation of those rights. How we can intertwine the society, those who are providing those helps and accessing, how they can have that access of their rights. So this is first part, which I think when we talk about the health concern, may be the geriatrics, gerontologist, or the legal luminaries. We can work in this way. Second is abuse-free society. When we talk about abuse-free society, that is age-friendly society for all ages. This framework, as the previous speaker has talked about the UN decade of healthy aging and all age-friendly integrated approach. So I'm skipping that part. But based on all these worldwide discussion and discourse on this aspect, WHO has announced that age-friendly city based on for developing guideline to make frontline primary health care. Now, who are they for frontline primary healthcare providers? Now, whether we are able to see in India, if we talk about how and where they are working. So that is actually the lack of awareness is happening over there. The system is there, it is on paper, things are working at national and international level, but things are not visible. So this was my serious concern in my project, which I have witnessed, because it was my research was based on two aspects. One is the help the care provider and the caregiver both, the receivers and the providers both. So when it comes to the care provider, so I thought that this particular part is missing as far as awareness is concerned. Now for this, in my research I found that when we talk about the care providers, forget about the victims and forget about the abused people, those who are from the senior citizen section, the care provider itself notified that we have very much lack in having a present status of age-friendly cities in India. And I'm talking about the most developed cities of the India, the people, those who are coming from there. So the good environment is missing. Now here, global initiatives are there on paper, yes, and people are working for that also. But to understand the role of urban development and age-friendly city, where the measures and the monitoring on those measures are working, so this part we have to see in very serious way. That is my submission over here. Third thing which I want to convey from this forum is call for action. Now, integrated research for elder prevention. For this particular thing, the community care using geriatrics, gerontologists, and please mark my word, specifically the students and the scholars, those who are listening to me, quantum physics. Imagine, I'm giving two example over there. There are two things. If you have an old age home and you have a quantum village over there, quantum village where all the technocrats and innovators, scientists, and quantum physicists are working to help the elderly people. And you have, on the contrary, you have an old age home where people are working emotionally charged. People are working, the volunteers and the society. These are two different things, and things are working like this only. Those who are the intellectual minds are sitting over there, and I can assure you, all of them might have experienced this, that the technocrats are working at very hard. They are working to develop something to help the elderly people. At the same time, social workers are also working, but the amalgamation, the intertwining of both the things is somewhere missing. That is what I have found in my research. Now here, what is my submission is this call for action urges researcher, gerontologists, physicists, and especially the policymakers collaborate with each other. Now, when we talk about collaboration, I have a focus group discussion and specifically a focus interview with a quantum physicist. His name is Analki Sinha. He's a quantum activist, and I had a word regarding this, that what could be the probable solution for it from the science point of view. He has worked with Dr. Amit Goswami in Hyderabad, and he has played a crucial role while discussing and deliberating and creating an international education program focuses on transformation out of his work and leadership coaching projects. His coaching philosophy is grounded in the principle of behavioral change with a focus on enhancing self-awareness, emotional intelligence, and overall leadership effectiveness. Now, while talking with him, how we can discuss the concept of quantum activism and social responsibility of gerontologists, how we can work in this direction. This was the entire the sum up of the discussion, focused discussion on this particular aspect, which I want to share with you. And further, we can work upon it. The people, the geriatrics and gerontologists and the other disciplined people, those who try to work on this and find some solution. How quantum activists...
Please, can you wind up soon?
Yes, ma'am. Yes, ma'am. In 2 minutes time, I'll wind up my things. So quantum activist Anil K. Sinha has produced this quantum activism visual aim. Now, how a student and teacher at one level, then quantum village, co-creation through the technocrats and the scientists. Parallelly, they can work separately, and then learning and consulting then how collective participation of co-creation can be developed. That model should be provided by the scientists over there. And then consulting for others and sustainable creative communication regarding this. All these things should have at different level, and there should be a model where all of these can work together, and we can have supporting human creativity for elderly care, innovation and professional thoughts, the thought leaders for elderly care, pursuit of joy, happiness, abundance, creative, better solution for the world, model for global community, and then living demonstration for future replica. Now, this entire thing will have a serious thing. I'll only talk about 4 things. That is quantum activism, students and teacher coordination for working to support the elderly, quantum village, how we can develop quantum village with sensitivity, with emotionally charged volunteers. Now, sustainability and creativity and thought leaders over there. For providing all these, there are so many things which I am skipping on. I'm coming to the last topic of my model, which I was discussing. But the quantum village and social gerontologies as complementary framework addressing the needs of the elderly population through a combining scientific innovation, community participation, and social responsibility that can work. The last thing which I was saying, that the model can work in this way: support for age-friendly society. Swavalamban is an initiative by the central government where senior citizens with mental health issues can ask the rehabilitation. This is for students to note the Department of Empowerment of Persons with Disability. They are supporting them. And secondly, the 6 states are getting this helpline number. You can note down, and definitely you cannot see elder abuse and keep mum. Lastly, if the students from Rajasthan can have this number. And last slide, which I want that the forum should think over it, and especially the RC 12, how RC committee can support all these things. It is collaborative research and awareness, we all know, but the feedback mechanism, where the establishing mechanism together, the end user and the continuously working people for this particular aspect, improve the application of research and technologies. This is my submission for this day. So any research is of no use if we are not able to determine, examine, adequate despite having great ideas, attitude for research. Thanks a lot.
Thank you so much, Professor Rao, and I really find your idea of quantum village worth taking it forward. Thank you so much.
Thank you, ma'am.
Dr. Pratibha Desai, can I request you to please begin with your presentation?
Yes, ma'am. Shall I share my presentation from here, ma'am?
Yes, ma'am. Admin can share the slides if you have.
I have my share. Ma'am, now I have shared it. Is it visible, ma'am?
Yes, it is. Could you switch on your video as well, ma'am?
1 minute. I will switch on my video.
What, ma'am? Yes, yes, it's visible. Yes.
Respected dignitaries, convener, and chairpersons of today's session. And slightly, actually, my topic is slightly very different from old age. Just I have to I want to highlight the gender and health. In health sector, in health, how there is the gender discriminations, and particularly in the reproductive health of the rural women and the right of the rural women. And because I have taken actually gender health, or the discrimination of gender discrimination is to be the exist still from we can say from to the tomb. Actually, whatever we are saying in the elderly abuse, we are just still mourning from many sessions are to be going on, and everyone is to be discussing about the elder abuse, or either elder abuse or women abuse or abuse. Actually, abuse is outcome of the gender discriminations, and particularly that of the patriarchy, where particularly in Indian society, the social system that patriarchy allows the abuse, and that also prevailing in the old age also, and that is the point. But my topic is here the reproductive health of the rural women, where how the gender discriminations, particularly the broad topic is the gender and health, but I have restricted it to the reproductive health of the rural women, and how the gender discrimination has been seen in the particularly the rural reproductive health. Because being in the health sector, we are saying the health care or women health, elder health, but the reproductive health is not to be publicly not spoken in India, particularly in rural as well as in the urban areas. Because my study is basically based on the IMPRESS project of the ICSSR, and we have conducted the data, that means conducted these studies in the 5 districts of the Western Maharashtra. But as usual, when we asked we conducted the interviews of the women, they are saying nothing. There is no any problem. There is no anything, because and we didn't get any accurate data about the reproductive health, because women actually literate or illiterate women are not going to talk about the reproductive health, because it is not to be because of gender discrimination as well as the societal. See that my presentation is to be divided into the introduction, concept, reproductive health, rights, reproductive health of the rural women, major reproductive health problems, reproductive rights, and how the gender discriminations has been prevailing in the particularly gender discrimination, and some findings of the research. And we all know that what is the definitions of the health, and how the gender discrimination is the prevailing health, because health is not a biological component. It is to be literally linkages between health, social, cultural, economic, and political spheres. And so because of that, health is to be it is to be determined by social also, it is to be determined by culture also, and it is to be economic, and it is to be political. Just first inaugural sessions, Mala Kapoor ma'am has to be told that there is the social, biological, medical, and the cultural the factors are affecting the old age. So that's why the old age problem is because of the socially also, and because of the medically also, but abuse particularly because of the social, where the gender discrimination may not allow to enjoy health of the women, either it is to be the reproductive health or the health of the elderly. And now the provision of health should be, some earlier presentation has to be taken as the right-based approach of the older to solve the age-friendly society, or the society of the free from the abuse. So right-based approach is to be, ma'am has to be told. So at actual health of the anyone's health, either old age people health or young people health, it is to be the fundamental right. So attainment highest of health is to be the important social goal of any society. So that is to be the must, and the social factors or any other factors determining to avoid this fundamental right, we should find out them, and we should follow up them. See that in concern with rural population, there is the 68.80% of rural population is reside in the rural areas, and remaining are the urban areas. So the rural women are working in unorganized sector as well as urban women also. So social discrimination against women result in a systematic neglect of the women's health from womb to the top. See that social discrimination, womb to the top means here the old people, young woman, old woman, even the health of the, hello. Hello.
Ma'am, please continue.
Hello. Hello, is there any problem?
Dr. Desai, please continue. Somebody had the mic on. That's okay now.
Okay, ma'am. Something disturbance is there, so I got actually the discrimination basically because of the in concern against the women, and as compared to the old men are as compared to the old persons and the male persons is to be the women are basically facing more number of the abuse in our society. Reproductive health, and see, this is only that I'm focusing on the serious problems very increasing. For example, these problems, for example, spread of and growing incidence of reproductive maternal child health mortality, morbidity, all will be, these are to be the problems of the young generation. For example, the people in the age of the reproductive problem, but this remains, it will be affect the health of the future, that means in their old ages. And this is the definition of the concept of Cairo has to be given, and I will not to be repeat this session. And just major reproductive health problems in India, the International Conference on Population Development, Cairo, it has focused the importance of women's health, particularly the reproductive problems. Only after the health problem is an important public health issue in the most of developing countries. So that's why.
Dr. Desai, can I request you to wind up in the coming 2 minutes, please?
Ma'am, is it not 10?
No,
okay,
it's 8 minutes. I'm giving you 2 more minutes.
Okay, ma'am. Okay, ma'am. See that these are the general severe reproductive health problems. Ma'am, because it is not concerned with particularly old people, so that's why you are saying, or it is 10 minutes is over?
Ma'am, 8 minutes are over. You have
okay, ma'am. Okay, ma'am. And sexually transmitted infections, tracts inspection, HIV, uterus, and these are the major gynecological morbidity of the problems. This is the picture of in Indian concern. These are some images will be reflect the Indians in concern with the Indian. Rural Indian. This is the sterilization, and some are the, and for example, just I will go for my last slide where the reproductive right is also has taken, and see that the health problem, in case of reproductive health problem, many women are having the reproductive health problem. For example, the side effects of the contracept not giving the gap between, they are not allowing, that means they have not decisions concerned with how many children should they have, or for example miscarriages or female feticides. All are, these are the some findings of my study. So the conclusion of my study is to be the gender discrimination should be addressed in the exercise of the reproductive rights. So it is necessary to create the awareness about the reproductive rights of the women as well as among the females. And majority of the women are unaware, but those who are aware not ready to reveal the particularly concern with the reproductive health overall, any health, for example reproductive health or health of the children or health of the old age, the gender discrimination should be addressed, and it is very necessary to create awareness about the reproductive health among the women, as well as now we are saying the elder abuse and how much the elder abuse will be affect the health of the elder. It is to be the very important for the discussion. Thank you for me giving an opportunity to share my views.
Thank you, Dr.
Okay, thank you.
Desai. Thank you very much. Dr. Chandrakala Diali is the next presenter.
Stop sharing.
Dr. Chandrakala Diali, are you here?
Yes, ma'am, I'm very much there.
Welcome.
Very good evening to all of you here, great presenters, organizer, and thank you so much, Mala ma'am, for having given this opportunity to me. I was whole day I was sitting, I was expecting that my turn would come at 3 o'clock. I was sitting in the library of Amity University to present, then quickly, you know, in the midway, I have halted to make the presentation. So before I present, I would like to introduce my title for the day, Elder Abuse of Public Health Issues in the Neoliberalized Era. So, you know, it gives me a lot of pain to really, you know, express that today why we are talking about elderly, why we are spending a lot of time on talking about elderly care, support, promotion, and elderly abuse at the end of the day. I mean, when we know it's just older adults are, you know, it is one life stage in a lifespan of
Sorry
humans.
to interrupt you, Dr. Diali. I just wanted to
Yeah.
know whether you're going to have a PPT.
No, no, I'm not going to
Okay,
have.
that's fine. That's fine.
Because I'm in the midway, I am not able
That's
to.
perfectly fine. I just wanted to
My
clarify.
mobile is supporting it, so it might cause problem, ma'am. Let me
Very
just,
well.
how much time do I have, ma'am? Do I need to hurry
Ma'am,
up?
you have time till 7:30.
7:30. Okay, fine, ma'am. I'll try to make it a little faster. So it gives me a lot of pain to express that why we are talking about elder abuse at the end of the day is because, you know, somehow our socio-cultural structural change have occurred, you know, with the passage of time, now innovation, you know, all this and one of the reason why abuses is happening and, you know, older adults are suffering in the home environment is because the nurturer and nourisher used to be the young woman, you know, in the household and all. She's already become part of the you know, competitive labor force. So she's not able to give 100% to nurturing and nourishing of her children, her own children, and the elderly in the family. And joint family has already crumbled down. Hence, we are not answerable to each other in terms of need and care support and all. In that case, you know, it becomes very, very imperative for us to understand as who's going to take care of the elderly, because it's one of the life stage and everybody has to go through that circle. So let us understand as what is a public you know, health. Public health is to do with you know, science of improving the health of communities and population by preventing diseases and injury and promoting healthy lifestyles, right? And many professionals are engaged in that, such as researchers, practitioners, educators, and microbiologists, behavioral scientists, and all. And what do? They help in screening, prevention of diseases. They helps us in treating, environmental monitoring, education, policy development, healthcare equity, and all.
I'm sorry to interrupt.
Yeah.
Excuse me, I'm sorry to interrupt. Dr. Ruby, I think you've made a mistake. We have to wind up by another 10 minutes, and there's still more presentations. It's not till 7:30. 7:15, the valedictory is supposed to begin.
Sorry?
Dr. Ruby?
Yes?
Yeah, sorry, there's a mistake you made. I think we have to wind up the full session in few minutes because the valedictory was supposed to start at 7:15. You've told Chandralekha that it is till 7:30. No.
No, 7:13. 7:13.
1-3.
1-3, yes.
Yeah, but if you can tell her to hurry up because,
because
you know, we still have, I think, 2 more presentations.
Yes.
Okay, ma'am.
Sorry, I'm
Well,
sorry, but you know, we are running late and we need to really wind it up fast. Yeah, thank you.
Please
and
carry.
yeah. So as far as you know, India is concerned, it is as far as older abuse is concerned, older adults abuse is concerned, 5.22% consists, you know, of the report says it's 5.22%, and Bihar is leading as far as older adults, you know, abuse is concerned. Karnataka is on the second with a 10.11%. So there is even gender differences are observed, as already being said by the presenter who presented before me. So, you know, there are many causes of older adult abuses. There are, it is because of, I'm getting lost with the, because, you know, there are many factors to it. One very important and imperative is because, you know, this is geriatric age and we bound to lose the spouses, and also living alone is one of the factors, and functional limitation is another factor that is causing a lot of elderly abuse cases. And The third one is low income. Low income is one of the very important factor because, if the income source is stable, then the elderly would be able to cater to them and look after their needs, and they become totally dependent on the other members of the family. So work status also, if if the elderly had not been saving and they had been working in the unorganized sector and all, that would not help them to save up so much. So hence they are liable to be, abused mentally, physically, socially, so many ways, financially, or maybe verbal abuses are there. So that those are the facts, right? And there are many, elderly public health issues had been catered by government also, and and many laws and legislation have been formulated in order to cater to it. But till date, Indian government has not been able to have a proper legislation as far as, elderly abuse is concerned in particular. So there are many ways they are trying to help. And elder abuse is a public health issue because it has health consequences, financial impact is there. It is, and many have already presented that, if been
Dr. Diali, you're not clearly audible. You're not clearly audible, Dr. Diali, and I also request you to wind up in the next 1 or 2 minutes, please.
Right. So I think it's because of my supported data collection, because there is a data training, it doesn't capture the pathological progression. So hence there is a more likelihood of elderly suffering with disability, infirmities, and all that. And institutionalization is another, because if elder abuses happen, and it has a lot of repercussion on their health and total well-being, and also they are hospitalized, they are put in the clinics and all those. So that becomes a big burden on the pockets of the caretaker. And social taboos is also there, since elder abuse is a social taboo across India and across the world. So there is a big burden on the not only on the family or caretaker, but even on the nation, because for elderly care support and sponsorship or financing or anything to do with elderly care, the government has to take the money from the taxpayers. So it has a big, it levied us with a lot of taxation and all because of elderly. And Japan is really struggling, being a developed country. Japan is really struggling as far as elderly population, rise in elderly population demography, because there's a demography shift and all. Hence, if it is so burdensome for a Japan kind of country, what would be the condition of India? So we've got to be very thoughtful. And as a professional social worker, what I would like to suggest is to Helpage India and some organizations, they are already working towards well-being and welfare of the elderly.
Dr. Diali,
And,
I'll have to request you to please wind up.
Yes. So what I feel is very important is, mobilization of the community is very important. Sensitizing the family to take care of their own elderly members of the family, and tapping the resources in and around in order to help the elderly population, and community advocacy has to be very strong in order to ensure that every household older adults are looked after properly. And not only that, we've got to advocate, mobilize, and then every one of us should be able to cater to the needs and requirement of elderly in and around in our community. Then only we'll be able to realize the dream of Saksham Bharat, or a developed country in days to come. Thank you so very much.
Thank you so much. Dr.
Ma'am, I
Manisha
have one
Jha.
question for madam.
Ma'am, the questions will be taken up later, please. You can type them into in the chat box and we'll take them later if time permits. May I now request Dr. Manisha Jha, who's the last expert for the evening today. Following which, Smita Chakravarti, Manjula, and Rakshanda, I really urge you to be very, very brief, not more than 2.5 minutes each. Dr. Manisha Jha, please, could you please start?
Yes. Yes, ma'am. Thank you very much. I would like to just thank the ISS and RC12 for this opportunity. And I also like to thank Professor Mala Kapoor Sankadas and Professor Prabhakar for this opportunity for me. And with the permission of Chair Ruby ma'am, I'd like to start my presentation. I'd like to have my PPT. It's a long PPT, but
yes, ma'am, but unfortunately you'll have to be very brief because
I know, ma'am. I will just try to be quick.
I know it's unfair to the speakers, but certain things we have to compromise on. We can't really go on. Sorry.
I understand.
You can present now. You're
now. Okay. All right. Okay. Thank you, sir. Is this visible? The PPT is visible?
Yes, it is.
Yes, ma'am. Thank you very much, everyone, for giving me this opportunity. And we are here whole day listening and talking about the elder abuse. And I'm going to talk about this the same way. I just would like to, everyone to think about the older adult that you care about. Maybe they could be of the age 60s, 70s, 80s, or even 90s. That means a lot for you. By doing that, I would like to draw your attention that, and then imagine that the person have been harmed by another. Maybe it's an verbal abuse, or imagine someone tells them that they are very slow, or they are very confused, or they don't care, and they're just taking too much of space. Or maybe they were denied food and not given clean clothes. And basic necessities, maybe someone you trust, they took that from their lives. And the financial support they also have, they make them financially insecure. And this can happen to anyone. And we have already discussed so many things about it. I would like to go through these slides that how we define aging. There are many ways to define aging. The chronological, biological, psychological, and definitely the social aging that can be defined. And there are many definitions of aged also. It varies from 40, starts from 45 to 65 and so on. The Indian census, they try to define old age by 60 plus. So all the things these have been already discussed, so I will not take much of the time. I would like to say that older person today are more visible because of the demographic transitions that are taking place. They are more active, they are more independent than ever before because they are living longer, they are having better health. But as the population of older people growing, do you think their problems are being taken care? No, of course not. There are hidden problems that like elder abuse, exploitation, and neglect that still needs to be taken care by the institution that they are the part of. Then talking about what is the elder abuse that we already have discussed, I'm going to skip these slides. There are many types of abuse: physical, sexual, emotional, financial, violation of right, and the neglect. Is it okay, ma'am, or if you want, I can go through the slides because
ma'am, as soon as you can wind up, that would be nice.
Talking about the abuse, how abuse is physical, many people, they must not have heard about the elder abuse. They only believe that if it's not if it's physical only, then this is called to be a abuse. If it's not physical, then it's not an abuse. But in every 6 senior citizen face abuse. 1 in every 6 senior citizen, they are facing abuse. According to many studies, the prevalence of elder abuse in India ranges from 9.6 to 61.7% across different states, and it is increasing every decade. And of course, who are the victims of the abuse? The abuse are the elder females. As the number of females are increasing, the most victims of the abuse are the women. Older women are particularly at the risk of their because of their financial insecurity and other social insecurities they are going through. And there is a study conducted in 22 cities in 2020. I found that 35% of elder in India suffered abuse by their own sons. Although this is the data, somebody was asking how we understand the Karnataka is having 10%, Bihar is at the top of the abuse data, and this is done by in 217 to 218, and I'm not going into the detail, otherwise it will take itself another.
You can move on to your conclusions if you don't mind.
All right. As I have talked about, I'm really sorry. I was so waiting since morning to go through all. These are the kinds of abuse faced by.
Was rather long, and
I understand. And this is, I just wanted to show how the abuse has increased substantially just in 1 year. And even after the pandemic, that it added on to the pressure or the negative behavior on the elderly people. And there are who are the abuser. As we think, we have the culture of respecting our elderly by saying that Matri Devo Bhava, Pitri Devo Bhava, the parents are as equal to the gods. But we all are surprised to know that the son and the daughter-in-law, this is the data, who commit the very own your family members, they are the one who abuse their own family member. This is very heartbreaking. And these are the warning signs, how we can understand. And the role of caregiver, and this is the health effect that is happening. And the science, these are the implications that have been discussed by many of the things. This is one of the important things that I wanted to draw your attention towards. The social factors that are contributing to the elder abuse. Ageism is one of the important aspects. As talked about World Health Organization published one data tracking abuse of the older people, and they prioritize 5 priorities in which the abuse, one of the priority, abuse is the very first important major reason why the older adults should be given attention, because of the ageism. And it has a negative impact on the elderly people in all the aspects. Think about the social, emotional, definitely economic aspects are there. These are the effects of ageism. It could be, these are the, I have talked about, I love to talk about the types of ageism, how this affects your own self-esteem and your own energy to just deal with the changing situations that we are dealing with.
These are the again you to wind up in the next one.
Yeah, I'm done. I'm almost.
All right. Thank you so much for your cooperation. Sorry for pushing you.
Anyways, it's okay. I understand the pressure on the organizers to be on time. These are the salient features, how we can prevent. There are many things, the barriers I would love to talk, but as we are running short of time, these are the roles, how the healthcare professionals, as I have already talked, the social factor contributing, the females were used to be the primary caregivers for the elderly or the person who are in the need, and they are occupied with other jobs. So the abusive circumstances are there more that affecting elderly people. And these are the healthcare professionals, they come to support the caregiver function of the family, and they have a very important role to find out and identify the problem, and then they can intervene, prevent, and provide medical and psychological support. And these are some of the findings. Elderly people, what are the percentage, if anybody wants to go into detail or can have. This is the important that elder abuse is prevalent problem in our society with thousands and cases going on everywhere. And there are unreported because of the family pressure, stigmas faced by the elderly, that they have, who will, if they will report it, who is going to take care, and what about their own, the honor of the family is going on the stake. There are many issues, many problems that are.
Thank you so much, Dr. Jha. So sorry to interrupt, but it was indeed a very interesting presentation. And
I was
you had more time.
Of course.
I now request Smita Chakravarti, Manjula, and
thank you, Ruby ma'am, for thank you everyone for. I just rushed so fast, so that thank you, ma'am. Thank you.
Thank you. I would suggest to Smita Chakravarti, Manjula, and Rakshanda to quickly give a summary of your findings and not get into making a presentation through the PPT, because that will take much longer. You have just about 2 to 3 minutes.
Absolutely. I'll be winding up within 3 minutes. I give you my word for that. No PPT as for now. Anyway, so I'll just quickly go on to my presentation. One of the respondents had asked me a question while I was conducting this research. When you were a newborn baby to your parents, did they ever separate you from them? Then why today do the younger generation feel that the elderly parents should be kept in isolation in the name of medical treatment in a hospital setting? Why don't they understand that we will recuperate faster, both physically and emotionally, if we are with them? So with this question in mind, I'll give a very brief overview of my study. The study has been conducted in the Noyagram block of Jhargram district in Paschim Medinipur in West Bengal, using discourse analysis. Around 30 respondents belonging to the age group of 65 to 80 years have been interviewed in this study. The prime objectives of my study are, firstly, to examine the role of religious beliefs and practices in influencing the health and well-being of elderly individuals in Noyagram. Secondly, to explore how faith-based support networks may mitigate instances of abuse among the elderly. And finally, to investigate the ways in which religions and cultural systems shape societal attitudes towards elder care, health, and frailty, and how it may prevent elder abuse in the community. So this research paper basically tries to explore the complex interplay between religion, health, and elder abuse, focusing on the frail elderly population of Noyagram. The paper delves into how religious beliefs and practices can affect both physical well-being and social experiences of elders, particularly in terms of vulnerability to abuse. So in this context, the faith healers of the region are more trusted than any other medical professional or any other professional caregiver. So the prime reasons pointed out by the respondents for being reluctant to visit a doctor or any biomedical clinic are, firstly, fear of alienation in a hospital setting, to be physically away from the family members, fear of expenditure, cultural differences between the doctors and the patients, language barrier, fear of abandonment of a few of them, as they have claimed that, they're aware that few younger generations, they kind of abandon their frail parents in a hospital setting and never come back to fetch them. And finally, lack of female doctors. On the other hand, they trust more, they place their trust more on the faith healers or the traditional healing practices when it comes to healthcare, because ease of communication, availability, affordability, accessibility of the faith healers, generations of trust upon the practices, use of herbal medicines, so fear of side effects is kind of curtailed. Religion acts as a source of resilience for the frail elderly in Noyagram. Therefore, there's a need to recruit medical volunteers to reach out to them and help remove the apprehensions they have regarding the biomedical world and create a holistic system of caregiving. Because we have to remember, the word heal is a part of the word health. So I would like to end my presentation with a small seminal quote by Hippocrates, that it is more important to know the person who is suffering from the disease than the disease itself. Thank you so much for your
Thank
patient
you.
hearing.
Very interesting and very, very brief. Thank you so much.
Thank you,
Manjula, another 2 minutes, bus 2 minutes.
Good evening, ma'am. I would like to thank the organizers and directors and participants.
You're not audible. Manjula, you're not audible.
Is it audible, ma'am?
Dr. Manjula, GK, you are not audible.
Ma'am, now?
There is some disturbance at your end. Dr. Prabhakar, what do you suggest? Should we ask the next speaker to come in while she fixes her technical glitch?
Hello?
Hello?
Hello, ma'am?
Yes, ma'am, you will have to
Dr.
raise the volume.
Dr. Manjula, please use some headphone or some mic because phone will not help you.
I'm using headphone.
Can we have Rakshanda to start so that Manjula can fix her
Yes,
technical?
ma'am, I'm here. Am I audible to you?
Is that Dr. Manjula will come back to you in 2 minutes after Rakshanda finishes her presentation. Is that okay?
Ma'am, Rakshanda here. Am I audible?
Yes, Rakshanda, you have 2 minutes.
Yes, ma'am. Thank you. Ma'am, my topic is on financial abuse of the senior citizens in Goa. It is a sociological case studies that I have done. These are the elderly who are staying in old age homes. And Goa is one of the states which have the second highest population of elderly living in the state. And there are 65% of these elderly who are living in Goa, according to a survey, who have been financially exploited. And I'm studying the financial exploitation of these elderly. So my objective of the study is to investigate the common forms of financial abuse experienced by these elderly, exploitation of dependency and displacement from their own property, that is their own house, unsolved property issues that they have, economic deprivation and employment exploitation, for which I have done 3 case studies for each. And for the first case study is of an elderly woman who's been staying in an old age home. She have children, but because of a property dispute, she was so much in stress that she tried to commit suicide. So the financial abuse have led to her to harm herself physically. The second case study which I have done was of another elderly woman who was exploited at her work, and because of which she was, because of the stress that she had at the workplace, she got paralysis. So again, another impact on her health. The third case study that is there, it is of an elderly man who was abused in his own home by his own children. They used to torture him when he used to eat food. They used to throw stones in his food. So because of this torture, he was again admitted. So what is my result in this? I will come to the results and discussions of my case studies is that all these 3 cases that I have, they have children and they're exploited financially, and financially exploitation of financial abuse have led them to have physical abuse, domestic abuse, emotional abuse, and also psychological abuse. And these abuse was by their own relatives and outside their home. So there were abuse within the home and outside their home. And this type of financial abuse was seen in property related abuse, employment exploitation, and neglected dependency. So because of this financial abuse, there was mental and emotional abuse, domestic abuse, and it was seen that this pattern of abuse is common in all 3 of my case studies. So I would like to conclude my study by saying that financial abuse is one of the major cause for the other forms of abuse, such as emotional abuse, domestic abuse, physical abuse, and mental abuse. And it also have a direct impact on their health. Thank you, ma'am.
So much. Thank you very much. Manjula, can we now hear you, hopefully?
Audible, ma'am?
Not really, but what should we do, Dr. Prabhakar?
Hello.
Carry on, ma'am. Maybe you need
Carry
to...
on. Ma'am, please give her at least 2 or 3 minutes. She can do that.
Yes. You can start.
First and foremost, I would like to thank the organizers and the ISS and RC12 convener, Professor Prabhakar sir, and the chair and the co-chairperson for giving me an opportunity to present the paper. So my paper titled "The Problems of Aging: A Sociological Study." Human life is all stages is blessed with the growth and development. Aging is a multi-dimensional phenomena and is affected by the combination of physical, psychological, and socio-economic factors. The United Nations declared the year 1999 as the International Year of Older
persons. In India, the national policy for older persons was announced by central government in January 1999. Old age is the last phase of the human cycle. According to the Urlock, old age is the closing period in the lifespan. It is the period coming from more desirable periods or times of usefulness. The social aging denotes the changes in the behavioral patterns of and the role and the status of individuals in the family. It is the behavior patterns, beliefs, and other products of a particular group that are passed on from generation to generation. Each society has its own languages, dress, work, costumes, and food habits. The case of the growing number of the aged in the millennium depends upon the policies and the programs implemented for them.
Can you move on to your findings, please? That would be interesting. We don't want to miss out on your findings. Can you quickly move on to your findings? You have 2 minutes, 1.5 minutes.
The Indian culture expected the girl should be under the father control, that a wife be under her husband control, and that an aged mother should be looked after by herself. The culture aging gives importance to the role of an individual during his lifespan. The individual plays different roles according to the stage in life pursued the childhood, earlier adulthood, middle people, and late adulthood. They are supposed to play the role of the son, daughter, husband, wife, father, mother, and the grandfather. In the Hindu tradition, the Vanaprastha ashram is considered a stage of old age. Once they fulfill the duties and responsibilities of the family, they retire from active life and follow heritage. The socio-economic security of the older people has to be done by the families. As the families are breaking due to many reasons, the security of the older people has become a big problem to the society government. The government has taken various measures to protect the aged persons still. There is a need to assist the government in its activity by the non-government organizations and other societies. Old age homes are in need today as the lifestyles are changing fast and diminishing acceptance of the family responsibility towards their one's elders.
Dr. Manjula, you may please wind up soon in a minute.
Yes, ma'am. Thank you, ma'am. I can understand. Thank you. Hello?
Hello, yes?
Yes, ma'am. Thank you. Thank you for providing me an opportunity. Since you told me 1 and 2 minutes, ma'am. Hello?
Dr. Manjula, are you through with your presentation?
Yes, ma'am. Yes, ma'am.
Thank you. Thank you so much. Thank you to all the experts here and the presenters. And I now request Mr. Ziauddin to please take over the summary session, and also if there are any questions which anybody has for the speakers. Mr. Ziauddin.
Thank you, Professor.
Yeah.
Yes, thank you. In fact, I'm sure Professor Mala Kapoor is running short of time.
Yes.
I just wanted to say that I thoroughly enjoyed some of the papers, and then they were all really intersectional in terms of perspective and putting things into context. Let me also congratulate the entire paper presenters. We could not have question answers one-to-one, but definitely we'll be sharing, organizing committee will share emails and contacts so that people can raise their questions to each other. So let me thank Professor Mala Kapoor and our friend Professor Prabhakar, the entire committee of RRC 12 for really making this day wonderful in terms of putting various concerns on elder abuse. I do work in this area for some time, and it brings a lot of questions for us to look at interdisciplinary. So I would not comment on any of the paper rather than thank and congratulate the team. The team is our team, RC12 of ISS, and Professor Ruby Bhardwaj for really making it very successful session, because the way you could push up for all papers is always morally not correct, but then as a chair you could do that. You have to do. I could long time. You are our most super senior from day school, so it's also I'm also happy to see you that you were chairing in the same session. I would not say anything more than that. Thinking and seeing Professor Prabhakar just staring that I should not speak more. So congratulations everyone for the last session, and I am thankful to the team for giving this opportunity. Prabhakarji, over to you, and Professor Mala Kapoor.
Yeah, thank you, Professor. Yeah, and I thank Dr. Ruby for chairing this session and making it very successful. And thank you for this. And we'll move on to the next session.
Thank you, everyone.
Thank you, Professor.
Most welcome, sir. Thank you.
Dr. Kapoor Shankardas?
Yes.
Yes, we are done with the session.
Thank you very much. And now we start with the validatory session. And I want to thank all the chairs for the technical sessions, for doing a great job, and all the expert speakers for fantastic presentations. And we move on. Okay, so greetings to all as we come towards the end of our international webinar on a very pertinent theme, elder abuse, a public health and well-being challenge. With now we are on the validatory session, which is a very important thing because we wind it up with the right approach, perspective, and sharing of thoughts by experts. So you would all agree that this has been an extremely enriching day with over 6 hours of listening to all very informative talks and presentations. There has been good learning, sharing of expert views, and nice interactions in the chat box. Significantly, we discussed new dimensions of emerging discourses in the field. And we had speakers from different parts of the world with excellent deliveries from 12 different countries and from India, but also importantly from various regions of the country. This has been remarkable, and I'm sure all of us are now looking forward to 2 special addresses, one from USA by Dr. Yunus and another from Dominican Republic by Dr. Pereira. Both are touching on crucial aspects to which we are eager to listen. So is Dr. Yunus, has she joined? Because she was sending me messages that she's getting late in some meeting.
Yes, I am joined. I'm here.
Oh, thank you. Very nice. So now I invite Dr. Yunus for her delivery. Yes, Dr. Yunus, please take it on.
Okay. Thank you so much, Dr. Mala. How much time do I have?
Actually, we are running late, so 10 minutes. Would you be fine with that?
Yes, I think so.
Thank you so much.
Can I share my screen?
Yes, please.
Okay. Okay.
Now you can share it. I have made you co-host, ma'am.
Okay. Just give me a few minutes. Okay, I think this should be in the presentation mode now. Okay, can everybody see the slide now? Okay.
Yeah, it's visible. It's visible.
Okay, right. So I'll just be very quick. First of all, thank you so much for having me here. It's morning. It's actually quite early morning here, and I'm kind of crammed in between meetings, so I'm really sorry about that. I'll go rather fast. I know, I mean, from what I can understand, I think we're moving towards the end of the conference, and thank you again for having me. So basically, I am a postdoctoral fellow. I'm now at the Medical College of Wisconsin. I'm originally from Malaysia, and I have been researching elder abuse maybe since 2015. So that's like almost 10 years now. I believe most of the experts have already touched on the overview and the basics of fundamentals of elder abuse. So I don't think I have to repeat any of that. So I'll just kind of skip some of the slides and focus on one specific subtype of abuse that I want to talk about today, which is elder financial abuse, or I would maybe shorten it as EFA. So I'm not going to talk about the, global aging phenomenon and all these things. I'm pretty sure all of you are already very familiar with this. These are just some, okay, sorry, before that, can I confirm that you can see my slide moving?
Yes, ma'am.
Yes, okay, that's great. Okay, moving, that's great. So as you know, we have this definition of elder abuse by WHO and CDC, and basically it is a single repeated act of commission or omission. So it can be active, it can be passive, right? And it occurs within a relationship of trust that causes harm. So to me, the keywords here is basically an act of omission or commission, and then the word trust, and then the word harm. So as long as these three come together, then that constitutes elder abuse. So we have different subtypes, and I'm not going to like go through all of them. I know we've talked about that. So I'm just going to focus on one today, which is financial abuse. And you can see there that how it is defined. It says that illegal, unauthorized, deceptive, or improper use of elders' money, benefits, belongings, property, assets, or for the benefit of someone else other than the older adult himself. This is just a very quick slide to show you the prevalence. And I know there are so many studies with different, figures that they will tell you, but this is what I'm showing you, this 15.7%. I know is kind of covered by this, but this is based on a systematic review and meta-analysis in 2017 that says in the community dwelling, elderly, so basically the prevalence of abuse is about 15.7%, whereas in the rural setting, they say that it's probably higher. And then if you look at this slide, the percentage in white, that is the prevalence of abuse within the community setting, and then the percentage in red is the prevalence within institutions. So you can see that in nursing homes, for example, for every subtype, the prevalence of abuse is a lot higher than compared to the one in the community dwelling. So pay attention to financial. I know that from here, it seems that financial is probably like the third highest, but more recent studies, if you look at the papers within the last 2 or 3 years, more and more experts and scholars are actually saying that financial abuse comes either first or second. So they are saying that the highest one is actually psychological or emotional abuse, and the second one is financial. In fact, in some countries, some settings, they are saying that financial is actually highest. So what is actually the true prevalence? All these numbers that we see, these are just the tip of the iceberg, because as you see, you can see in my slide here that some experts are saying, for instance, for every one reported case, there's about 20 other cases that are not referred or are not reported. And another study, NRC, is saying that for every 14 cases, only one gets reported. So underreporting is very widespread, and the same goes to financial abuse. If all of you notice, and I'm sure all of you are familiar with journal papers on elder abuse topics, most of them would usually say that we exclude older adults with cognitive impairment, right? And this group of people is often excluded from empirical data or empirical studies because it's very difficult to interview them and to verify information. And they are also kind of like, here, let's say in America or in the Western country, they are a very protected group of people. It's not easy to access them. Now, this becomes a problem because once you exclude these people with cognitive impairment, you are basically underestimating the amount of abuse, including financial abuse, because cognitive impairment is one of the major risk factors for financial abuse. Now, what is the problem with the current elder abuse research? The problem is that traditionally, or I would say the conventional way of doing research in this area is that abuse is seen as one single entity, right? It's like as if it's homolytic. So the whole of abuse is one, but that's not actually the case because we tend to disregard the different dynamics and risk factor for each abuse. So all this one size fits all approach is really, is not actually the best way. And then because of that, we fail to discern and pay attention that to the fact that each subtype is different. And in fact, many scholars are saying that among all these 5 types of abuse, financial abuse is the most different one and has to be studied as a separate area. So why is financial abuse different? Sorry about that. Okay. I hope I'm not going too fast. And can you all see this slide, why financial abuse is different? Is it moving, the slide?
Yeah, see, moving on.
Just checking in. Okay, so why is financial abuse different? So I would say that financial abuse is different from the others. First of all, because simply for the fact that many scholars who do research in this area are saying that it is just different, right? It's not like the others. Some evidence have shown that financial abuse is like the not exclusively, but often the only type of abuse that can occur in isolation. That means the victim does not have to be in close proximity. The victim does not have to be with the family members or the abuser in order for that type of abuse to occur. They can live separately, they can be far away from each other, but still abuse can continue to happen. Now, and then another characteristic that they found is that financial abuse is very much influenced by the type of relationship between the victim and the abuser. For instance, if we look at some cases when there is only financial abuse and no other types of abuse, most of the time it is committed by non-relative abuser. So when I say non-relative abuser, it could be someone who is still within the relationship of trust, but there is no blood relationship. For instance, maybe a very close friend, maybe a very close caregiver, maybe a neighbor, someone who the older adult trusts with his property or money. On the other hand, when it involves relatives, when I say relative, it can be children, it can be, daughter-in-law, son-in-law, spouse, children, whatever. So when I say relatives, usually the financial abuse will come with other types. That means it is a kind of poly-victimization, the multiple types of abuse coming together and not just financial abuse without other components of abuse. And then again, financial abuse is very closely related to mental health problems and cognitive impairment of the victim, but not necessarily the abuser. Now, there are three types, or maybe I would say three descriptions of how financial abuse can happen. I'll just go through very quickly. The first one is called occasion, crimes of occasion. The second one is crimes of desperation. And the third one is crimes of predation. So crimes of occasion is basically opportunistic. It's just basically something, a form of exploitation that happens because the victim just is in the way of what the abuser wants. So I want that money and you are in my way. Therefore, I'm just going to find opportunity when you are not aware. I'll just get what I want. So it's kind of very straightforward. But then crimes of desperation generally is a different situation where family members or friends are in a desperate situation for money. So they will just do whatever it takes to get it. And generally, this happens when there is some kind of dependency on the older adults for housing and money. So I believe that the second type desperation usually occurs when the abuser lives in close proximity or together with the victim, and there is some kind of sort of understanding and dependency where they share resources, but at some point, especially if the abuser has some issues with substance abuse, alcohol or drugs, then it makes it a lot easier for this type of crime to happen. The third type, which is crimes of predation, occur when the trust is engendered for a specific intention for abuse later. So this is some sort of grooming, I would say, that maybe the person has been planning and thinking that, okay, I'm going to target this person because this person looks vulnerable. This person trusts other people easily. I'm going to build a relationship with this older person. Okay, I'm going to make him love me. I'm going to make him trust me because I know he has something that I'm going to take. So that's how it happens. A relationship is built, and then that relationship, the trust, is used to financially exploit the victim. So I'm just going to let you have a look. I'm not going to read this. Maybe I'll give you like 20 or 30 seconds to scan through very quickly the examples of financial exploitation that is becoming common nowadays. You can see that. Like we have this sweetheart scam, right? Romance scam. We have all these contractive fraud, pigeon drop scam. You can see all these, like catchy names on the left side, but basically what it means, the definition is on the right side. Okay. I can definitely share the slides later if you want. So one thing that I want to say before going to this slide is that we need to understand that some scholars try to distinguish between financial abuse and financial exploitation. So some people, they're saying that when you say abuse, that means there is involvement of people in the relationship of trust. But when you say financial exploitation, the perpetrator can be a stranger. But some other scholars are saying that we should just kind of put them together because it's difficult to make these differences, and because of the fact that nowadays the type or the forms of financial abuse happening is moving towards the online version, right? The virtual scams and frauds. And it's, if we want to stick to the traditional conventional way of financial abuse, then we will miss out and we won't be able to capture the more rapidly evolving type of financial abuse that is happening nowadays. So then if you look at this slide, basically what I'm trying to say is that when we talk about financial abuse, we need to understand something, one term which is very important, which is called financial capacity. I put that as FC, or it's also called, some people say decision-making capacity, some people call it financial capacity, because financial capacity is the cornerstone of elder abuse. Now, what is financial capacity? It's just, I mean, in the simplest way to describe it, is just the ability for an older adult to manage his financial affairs in a manner that is consistent with his personal self-interest, right? I mean, all of us manage our finances every day, but as we get old, actually at some point, there is some sort of ongoing gradual cognitive decline that when a person hits a certain threshold, that ability actually declines significantly to make him not able to manage his affair in an effective manner. So financial capacity is an instrumental element of ADL. Now, I'm sure all of you know ADL means activities of daily living, and we have many tools to measure and older adults' activities of daily living to know whether someone can live independently. So one of the markers of whether someone can live independently or whether he should be, given full individual autonomy is financial capacity. If he can manage his daily finances smoothly and without help or without assistance. Now, there are 4 components of financial decision-making capacity, and it comes in sequence. I'm not going to talk too much about it, but just mention it very quickly. So the first part is for someone to understand, like, first of all, this first step is for you to understand, like, what it means, right? How, like, the amount of money, like, you know the value, right? And you know, like, what is going on, what is it that I'm planning, what I'm trying to do. And the second part is appreciating. The third part is reasoning, and the last part is choosing. The last step, choosing, basically means that you finally have the autonomy, or you are able to make decision to say that this is what I choose, right? And that choice is, of course, based on the previous step, which is reasoning, because when someone is able to reason, to think through the choices, the multiple options that he has, then only he will come up with the final choice. So very quickly also, you can scan through quickly. These are some of the red flags of financial abuse. So you can see, for example, like, so it says here, potential red flags, and an older adult is vulnerable or already a victim of financial abuse. So this is probably, it can be some sort of guide for maybe social workers or for primary healthcare providers, even for geriatricians. When someone comes to you, right, with multiple problems, multiple issues. So this is some of the red flags that when you see, if you detect any of these, then you have to take the next step to investigate further. Now, red flags does not necessarily mean that if financial abuse is happening, but this is just like a sign, right, to kind of just like catch your attention that, hey, maybe there's something wrong going on here. So you need to ask questions, or maybe you need to talk to this patient in private and not with the caregiver. So we have some tools to assess financial capacity. I'm not going to go through these tools, but my main point here is that if you see here, there are 2 tools here. I'm sorry, it's kind of covered. Let me just try to move it.
Dr. Yunus, I would also request you to
okay, it's time's up. Okay, sure. No problem. So I'll just maybe go through very quickly that when we talk about risk factors of elder abuse, you can see this nice diagram, but this is the risk factors for conventional abuse. But what I'm going to focus is the risk factors specific for financial abuse. And I'm going to talk specifically about technological risk factors. So these are the general risk factors. Okay, let's ignore this. These are the old ones. And these are the technological risk factors. So as you know that nowadays, we do a lot of virtual transactions, right? And even the older people are also moving towards that, right? Maybe not those who are 18 or 19 years old, but those between the age of 60, 70, many of them is actually using it. So when we use multiple modes of virtual banking, financial transaction, and increasing internet and video games, we also sometimes, in one house, we go to public, we use public Wi-Fi networks and all that. These are all actually the risk factors for financial abuse. Moving on to intervention, this is just this diagram is just to show the overall approach to intervention that what some scholars take for the whole of elder abuse, not necessarily financial abuse, but what I'm going to show you is that, okay, this slide. So for intervention for financial abuse, we don't have many studies yet, unfortunately. But we do have, like I came across these studies, Harris and L, and they show that educational intervention actually works, not targeting the victims, but targeting a group of professionals, right, to help them to detect financial abuse. So it's basically the people like us, we are the ones who are supposed to be actively detecting and asking and looking out for it, rather than putting the burden on the victim. And other considerations that scholars have talked about is, of course, having like more laws and regulations and the need for multidisciplinary team. But the emphasis today is always given on the fact that when we have an assessment tool or we want to do detection, we have to put into consideration the technological risk factors. Basically, we need to have an understanding of how technology works today that enables more people to abuse and exploit older adults virtually or financially. Last part, I guess, this is recommendation for future research. I would say I think this is my last slide. Okay, so my last slide, I would, in the future, I would say what, if you have interest in elder financial abuse, these are some of the areas that you can look at. First of all, the issue of conceptualization, like how would you define abuse when you start delving into elder financial abuse that involves virtual or financial transaction, because this will include a lot of strangers, people who are not in a relationship of trust. Whereas the conventional definition of elder abuse is that there must be a relationship of trust. So how do we reconcile that? The second one is that to push for elder financial abuse to be a separate field of study, because it's just so different from the others, and many scholars are actually moving towards that. So this is something we have to think about. The third one is that we need more in-depth research into risk factors, especially technological risk factors. I know there's a lot of studies on risk factors out there already, but most of them, they don't discern between the subtypes and they don't focus on financial abuse. It's rather like some kind of general study for the whole of elder abuse, treated as one single entity. The fourth one is that we still have very little evidence on what kind of intervention works for elder financial abuse. So we need studies that measures the impact, especially using interventional design, and especially if you can do some sort of randomized control or if there's some sort of blinding. I mean, basically what I'm trying to say is that we need to have a very robust study design to prove that if you come up with this idea that this is going to work for the elder financial abuse, it has to be designed in such a way that you can prove that it is impactful. And finally, of course, we still don't have a standard financial capacity assessment tool that incorporate digital financial technologies. So we do have some, and I know it's kind of evolving, and we do, I think, from what I understand, there are two latest one, it's in one of the previous slides, that have incorporated some elements of financial technology, which is great, but still there's a lot of study to be done. It needs to be validated. And I would actually encourage scholars to, modify or come up with their own assessment tool, which is contextualized, which is suitable for your own society, because you know best what works for your people, and not just rely on tools which are, created by in the West, for example, in America, because I would say the dynamics here and healthcare system, the social service is very different. So we need to be more nuanced in that. So I guess I'll just stop here. And thank you so much for having me.
Thanks a lot for a meaningful presentation, Dr. Yunus. Financial abuse is a very serious concern, and it is a growing form of abuse across the world, and in India, particularly, on which researchers should focus. So I'm glad and you took up this topic, and I'm sure many would have learned a lot from it today and will take forward research on this. I now request Dr. Rosie Priara to deliver her address. She is a close associate of mine in our work on elder abuse, and is currently Vice President of the International Network for Prevention of Elder Abuse, IMPIA, of which I am the Asia representative. So, Dr. Prayara, will you please start with your presentation? Are you going to share your slides? Can you hear me? Hello? Dr. Prabhakar, you are muted. Can you hear me?
Yeah, ma'am, I can hear you, ma'am.
Yeah, so can Dr. Prayara start her slides?
Yeah,
no,
made her
Dr. Prayara, do you have
co-host.
slides or you're going to speak?
Oh, yes, she's muted.
Can you hear
muted.
me now?
Yeah.
Can you hear me now?
Yeah, we can hear you now.
Okay, lovely. Well, thanks, Mala, for this invitation.
Could you be a little louder, please?
Yes. Thank you for the invitation. I can thank you, Mala. I know that how much and how long have you been fighting elder abuse in India? And I'm very glad to hear so many people that are involved looking at the subject. What I wanted to convey with you is the importance of data collection for the elaboration of public policy to prevent elder abuse. We know that while research on child abuse started in the 1970s, Centers of Disease Control, National Institute of Health, as well as other public and private institutions in developed countries have spent millions of dollars to develop a public health response to child abuse and domestic violence. But the knowledge as infrastructure relating to elder abuse lag decades behind. Recent research all around the world indicates that elder abuse is a significant and growing problem affecting, for instance, in the United States, 10% of people aged over 60 living at home who have and are able to use a phone, and the number is much higher for those with limited function, disability, or means to communicate. In the Dominican Republic 3 years ago, we did a research on incidents of abuse, and from 1,300 people interviewed, 91% of them said that they have suffered some type of abuse in the previous 3 months. As the population ages, caregiver shortages grow, and more people live to an age where they develop physical and cognitive incapacity. The number of people vulnerable to elder abuse will grow, but the problem remains largely hidden. And I saw that Julius mentioned that, as she said, it's estimated that about 1 for each case of elder abuse reported, 23 others remain unreported. But one reason why the response to elder abuse lags so far behind comparable issues is that it has not been recognized or treated as a public health issue requiring a public health response. Like other forms of violence, abuse and neglect, elder abuse is associated with law enforcement, prosecution, social services, and financial issues. However, it is also a problem that causes premature death, great suffering, and has major health consequences and costs for individuals, families, and society. To address this gap, one should begin collecting data, doing surveillance, determining what type of prevention and intervention programs are effective. And until this is done, elder abuse will remain in the shadows. Another aspect of the health problem is the serious shortage of trained workforce, to identify, address, and prevent abuse. There are 10 times as many pediatricians, many of them trained on elder abuse or child abuse, as geriatricians, few of whom are not trained about elder abuse, because there is not a subspecialty on forensic geriatricians. These shortages extend to most fields of health and social service workers focused on aging, including nurses, psychogeriatricians, and social workers. For these reasons, it is critical to recognize elder abuse as a serious public health issue and allocate resources accordingly. Why should we consider that elder abuse is a public health issue? Research is needed to calculate the unnecessary burden that elder abuse put on the health system. Elder abuse has devastating effects on victims and their relatives. Consequences of elder abuse include some physical injuries or illnesses that occur as a result of the abuse, such as broken bones or bed sores that can take months or years to heal. The psychological abuse can be very difficult type to uncover, since the abuse occurs within the confines of the home or behind closed doors, and it can be very difficult to see the signs of many cases. However, psychological abuse causes mental problems because it causes isolation, and isolation then goes to cause cognitive problems. Frequently, the victim is too afraid or too ashamed to denounce or tell somebody about the abuse because on the whole, they are abused by their own relatives. Moreover, victims of abuse are 4 times more likely than non-victims to be admitted to nursing homes and 3 times more likely to be admitted to hospital. And that puts a burden in the government finances. Financial exploitation has serious economic consequences, leading to people's lives causing dependency. Victims who do not go to facilities, they are taken away their money, but they cannot go to facilities, are likely to become more dependent on informal caregivers. And that data have shown that caregiving takes a huge health and financial toll on caregivers. And this is another uncalculated cost of elder abuse. Those are facts that we should present to policymakers that are constantly looking for ways to reduce health costs. And so they need data about ways in which elder abuse drains an overburdened system with avoidable costs. But which data should we then need to elaborate a public policy to prevent abuse? We need to know the incidence and prevalence of abuse. Areas, zones of this country where it is more common. Possible cause of abuse. Disaggregated data on age, sex, education, possibly social support, because people, age, women are more vulnerable. Education, those illiterate people increase their vulnerability. And if they do not have social support, we know that those people that don't have social support have more possibilities of being abused. It is also important to know the number of geriatricians per percentage of all the population, the number of social workers, the numbers of psychogeriatricians in the country, also the number of qualified geriatric nurses, qualified paid caregivers, hospital beds occupied by victims of abuse, the existence or not of a law that refers to elder abuse or a law of mandatory reporting. And that is important because in the Dominican Republic, we sort of promoted the code of right for the older Dominican. And abuse was included among the rights. And because of that, we have every Thursday a public defendant visualizing all the reports of abuse that have been done, because we have a line, which is a 24-hour line support, where people can report abuse without being vulnerable to know who did the report. So friends, relatives, neighbors are able to report abuse, and that has diminished the number of abuse in our country. It's also very important, once we convince our policymakers of the burden that abuse put in the finances of the country, you will know that they will start working in trying to elaborate a system where they can reduce abuse and their consequences. The creation of awareness campaigns can be critical means of prevention, but resources are needed for them. And it is critical to determine, what do we want to accomplish? Which audience we are going to target? I mean, all the people, families, caregivers, policymakers, or geriatric or public health communities. Because we need to choose the language that may resonate with the chosen audience. And also, what is the most effective dissemination strategy? Otherwise, awareness campaign can fall on deaf ears and waste precious resources. Finally, if we wanted to promote the elaboration of a public policy to prevent abuse, all NGOs working with and for the older population and members of the civil society must start working on data collection and research. We know that research means money invested, but we know that if we are here to get to the point, we should actually empower the older population to ask for resources to be assigned to that field and to consider a health issue, elder abuse. And when we convince them, they will know the benefit of the society as a whole. And it's also important to me to start spreading the word among the younger generations, because we all are going to age, and we really want to have a better world for everyone. Thank you very much.
Thanks a lot, Dr. Rosie, for bringing attention to crucial elements related to elder abuse. Data collection and documentation is indeed a pivotal tool for research and writing on elder abuse. Before I invite Dr. Prabhakar as the convener of RC12 to speak, I sincerely want to apologize to all the expert speakers, to the chairs and co-chairs of the 3 technical sessions, and the research presenters for the time constraint and rushing them for their delivery. My regrets also to those who could not be accommodated today, but I promise we will have more opportunities to work together. There has indeed been a very good response to my call for joining this webinar, and both Dr. Prabhakar and I, along with the other core members of RC12, are grateful for that. So in fact, I am now thinking of another program on elder abuse in November. I'm not sure under what organization we do it, but we are going to take forward research on this. I now request Dr. Prabhakar to share his thoughts on how we take this forward.
Thank you, Professor Mala Kapoor. Indeed, it's a great pleasure for me to be part of this as a convener of RC12. So, good evening, esteemed colleagues and participants. As we approach the conclusion of this impactful webinar, I would like to take a moment to reflect on the knowledge shared and the discussions we had today. Our exploration of elder abuse through various perspectives has highlighted the urgency and complexity of this issue. The insight provided by our distinguished speakers have shed light on the multifaceted nature of elder abuse and the diverse strategies required to address it. From the discussions on the public health perspective to the examination of legal framework and the preventive measures, it is clear that a collaborative and informed approach is essential. Moving forward, it is crucial that we translate the knowledge and strategies discussed today into actionable initiatives. We must continue to advocate for policy changes, enhance community awareness, and support research that address gap in our understanding and respond to elder abuse. Each one of us has a role to play in fostering a safer and more supportive environment for our elderly population. I urge all participants to carry forward the spirit of today's discussion into their respective fields and communities. Let us commit to work together, sharing resources and leveraging our collective expertise to make a tangible difference in the lives of older adults. Thank you all for your active participation and valuable contribution. Together, let us strive to build a world where elder abuse is not only addressed but eradicated, ensuring that every older person can live with dignity and respect. Thank you all.
Sorry, I think I was muted. So you couldn't hear me. So thank you very much, Dr. Prabhakar, to share your thoughts on how we take this forward. And before I invite Dr. Srivastava to give a formal vote of thanks and close the webinar as the co-convener of RC12, I, on my behalf, want to say a big thank you to all of you for being part of this webinar, which has meant a lot to me, as I think we have successfully contributed towards a lot of deep thinking on this topic of elder abuse that is affecting all societies and our country in particular because of the changing family relationships, changing social institutions, and various other economic and other perspectives, economic, legal, health, which is putting pressure on increasing the incidence and prevalence of elder abuse. So we need to stop it and we need to work together. Thank you. Yes, Dr. Srivastava,
Thank you,
please
ma'am.
do the honors.
Am I audible, sir?
Yes,
Dr.
very much.
Yes, yes, you're audible.
My video is not, complying with it. Please excuse me for that. So it's a great privilege for me to extend sincere vote of thanks in capacity of co-convener of RC12 of ISS. To begin with, I wish to acknowledge our collaborators, INPEA and DWRF, Secondly, I wish to convey sincere gratitude to Dr. Mala Kapoor Shankar Das, Madam, for her initiation of this webinar and by putting the idea to organize this webinar, for continuous support, cooperation at each and every level to make this event a great success by inviting experts from all over the country and from abroad. As ma'am said, from 12 countries, the experts participated in this program. Thanks is very small word, ma'am. But again, for your contribution, I'm telling thank you very much, ma'am. I am also overwhelmed to convey my heartfelt thankfulness to all respected experts and dignitaries for sharing their views, ideas, experiences, as well as research findings related to elder abuse to enlighten all of us and for sharing their valuable time. The success for this webinar depends largely on participants who registered themselves and showed their keen interest in this field of elder abuse and for attending the event with full patience and with full interest and participation. Lastly, I feel that vote of thanks by me is incomplete if I will not appreciate the endless efforts made by the organizing team of Dr. Prabhakar, convener RC12, his colleagues, students, core team of RC12, Dr. Bala Murugan sir, Dr. P.B. Desai madam, and all other for wide circulation and for their efforts to make this program a success. Lastly, but not the least, I wish to express my sincere gratitude to Almighty God for the blessings on us to work optimistically for the noble cause to prevent elder abuse worldwide. I'm very sorry. Kindly apologize me if I forgot to take the name of anybody who is directly or indirectly involved to make this program a grand success. Thanks to all once again. Thank you.
Thank you, ma'am.
So I think in the end, we should congratulate all of us. In the seminar program invite, we had said we will close at 8:30. It was 1:30 to 8:30. And we've managed to do that. And with all the pressure put on everybody, but I appreciate our being able to achieve this. And I would also like to say that it is endless effort of Dr. Prabhakar, who organized the technical part of this webinar so well and made wonderful slides and the invite and reached out to everybody through his emails. And I think now, Dr. Prabhakar, I think you are going to send certificates of participation also to the speakers and presenters and participants.
Yes, ma'am. Already we have made the model. So within 1 or 2 days, we'll try to send it to everyone.
Yes. So a lot of people were anxious to get that. And so Dr. Prabhakar has thought of it in a very organized way. Thank you all. And we see you next time when RC has another program. And I think Dr. Prabhakar hasn't announced and nor has Dr. Srivastava announced, but I am telling you, we are planning to hold monthly lectures on very important issues related to health, aging, and well-being. And we are working as a team to decide on speakers. We have few thoughts in our mind, and Dr. Prabhakar would be soon announcing. And again, Dr. Prabhakar has shied from saying, but those who are not members of RC12, we request you to join our hands, make this a strong research committee so that we can take up various issues with your inputs. So there is, go to the website of Indian Sociological Society, you would find RC12, join in, and you have option of annual fees or 2-year, 5-year fees, and it is very, very nominal. So thank you all.
Thank you, sir. Thank you, Prabhakar, sir, madam.
Congratulations, ma'am and sir.
Thank you.
Thank
Thank you, everyone.
Thank you, sir.
As
Thank you,
madam
ma'am.
requested, I request all of you to mobilize for more membership. Those who are RC members,
Yes, sir. We will try
kindly
for that.
mobilize for those who are not members. Please become members of RC12.
I would like to mention the prompt response, the communications through emails and WhatsApp messages. Everything was well organized. The program was given to us in advance and everything went according to the time. So I highly appreciate the organization skills of Mala ma'am and Prabhakar sir. Entirely, I thoroughly enjoyed the program, and I have noticed one thing, that throughout the webinar, the attendance of the participants is quite noticeable and worth mentioning.
Yeah.
Everybody was there throughout. And
Only problem we
enjoyed
had
the
with the Zoom, the restrictions of the participation. Otherwise, we would have had more than 300 people inside this webinar.
But
there was some
Prabhakar,
restrictions
sir,
in the
more
number.
number of participants have joined for YouTube also.
Yeah, YouTube, many people joined.
Number of more than
Dr.
the
Prabhakar.
participants are joining YouTube. Yes, sir.
Thank you
that's
everyone
right.
for your support.
We had participation through YouTube
Prabhakar
also.
sir, thank you for providing the backdrops also.
Yeah, so somebody has put it in the chat box how to become member. Please go to the website of ISS and you will find RC12 there and the details about membership.
Thank you.
Thank you everyone. We will meet you physically in the ISS conference in Munjal.
In December month.
Yeah.
Prabhakar sir, please provide some contact numbers as well, apart from the mail ID.
Yeah, surely I will share the contact details also.
Okay, I'm going to sign
Thank
off,
you, sir.
Dr. Prabhakar. I think you need to close it. You need rest also.
Yeah. Actually, ma'am, 8:30 automatically it will close if you want or not.
But this is the first webinar we have to attend it completely, sir, from 1:32.
Yeah.
Thank you, Desai ma'am.
Thank you everyone. We'll meet physically in the. Thank you everyone.
Thank you. Special thanks to Mala ma'am. Thank you.
Bye-bye, everyone.
Bye, everyone.
Okay, ma'am. Bye-bye.